All right, thanks to everybody for coming in for this special meeting of the Superintendent's Insurance Advisory Committee on May 7th. Ms. Butterfield, will you please list us the names of everybody who's calling in on the Zoom call, please?
Okay, there's somebody with labor relations, but I didn't get her name. I believe she's on. Jeff Bailey, are you 890-6623?
Correct. Can you hear me?
Yep, okay, that's Jeff Bailey. I don't know who 443-835-5000 is.
Hi, this is Tian Tian from Aon. We're helping Amanda Brooks with her part of the presentation.
What's your name, hun?
Tian Tian is spelled as Tian.
She's with Aon, yeah. Mm-hmm.
Yep.
Okay, no problem. And the 602, who's got the 602 area code?
This is Stephen Mackey with Aon.
Stephen with Aon. 704.
Jackson Wright with Aon.
Okay. We got 651.
Phil Danucci with Aon.
Okay, got it. All right, I'm doing it. Hang on.
Is that everybody, Don?
Yep. Oh wait, hold on. I got two more people calling in. Hi, who's 813 and who's 804 area code?
Hi, 804 is Corey Norbuta.
And you're with
Cigna?
Cigna? Okay. 804 area code. Who is 813?
813 is Nadia Almaneyer from Aon.
Nadia.
Okay, sounds good. Thank you.
Okay, Dawn, if anybody else calls in the midst of the meeting, will you please just text me and I will add them to the roster?
Yes, ma'am.
Thank you. All right. Before we proceed, are there any discussions for the April meetings minutes that we need to go over? If not, do we have a motion to approve them as written? Okay, so moved by Anthony Colucci, and we'll call Chris McAlpines the second. All in favor? And we're moving on. All right, Mr. Langdorf, programmatic savings to the plan, please.
Good afternoon, everyone. Can you hear me well through this? Is that good?
Yes.
I'm going to move your slides, Amanda. How come that's not Amanda, this isn't moving. Is it on this? That is...
I actually don't have a mouse, but right here, this arrow.
But it's not moving this one.
Oh.
I'm wondering. Technical difficulties, just 1 second. That's what it is. So this is off the computer. So you may want to have that guy available to switch back when you need to use your computer on that.
Okay.
All right. Sorry about that, folks. I apologize, and welcome to the meeting today. I do want to talk about this slide real quick, because today I wanted to put something on here just to reiterate to everybody and the importance of the committee. And so we put the purpose of the committee down below, and I wanted to read that to you if you don't mind. That the purpose of the committee is to advise, assist, support, and advocate for the Brevard Public Schools Health Insurance Trust Fund on matters that will strengthen the health insurance fund and health benefits for employees. The committee is expected to advise the superintendent or designee of recommendations for program improvement and information relevant to policies that affect BPS employees' health insurance and its trust fund. That comes directly from our charter. Today, because we're reaching that point of the year where we have to make recommendations to the superintendent, what I'd like us to do is if we can focus on the 3 areas that we already have set aside, and that is the programmatic savings to the plan design recommendations, and the alternate plan recommendation. Those are the 3. In addition, yesterday, we were asked to talk about the specialty pharmacy copay. So we will address that after section 6 on the agenda when it comes to that. So if we can kind of agree to do these things today, so we can at least get some yes or no's on the things we'll talk about, and then we'll be able to present that to the superintendent. That would be really the goal of this meeting. Anything that we can't resolve today from this, I'd like, if we can't resolve it today, maybe we come back next week, but I'm hoping we can resolve it today. And if you don't mind, I'm dying of breathing apparatus up here, and since I'm far enough away, I hope this is okay with everybody. We'll go to the next slide.
Mark, your slides aren't projecting.
There we go.
There it comes.
Okay. Let's come back here to the first thing on our agenda, and that really comes down to the tobacco surcharge. Now, we've talked about this throughout actually last year as well as this year, and really it comes down to, do we want to do a tobacco surcharge or do we not want to do a tobacco surcharge? If the vote of the committee is yes that we do, then we need to set the limit of that. We put $50 or $100 per month, and then the committee needs to decide on whether we do it as an affidavit or a saliva test. Now, at the end of the slides, and I'm going to shoot this back here.
Can I say something, please, Mark?
Sure.
As you're going through this and there's matters that require a vote, can we just pause and get it done and just take a vote and check a box and move on?
Sure.
Okay, I would like to call for a vote. Everybody in favor of a tobacco surcharge being added to the plan, please indicate by saying aye.
Well,
Aye.
we need to take a vote, so we have a...
What? Well, okay, we've got the motion. Do we have a second? Second, okay. I think we have discussion. I saw Anthony reaching for his microphone. Go ahead, Anthony. What were you going to ask or add?
A couple things. So this has a potential savings of $150,000 to $500,000. Is it true that that would not be until the second year? Because it's not only a savings, it's also generating revenue.
Income.
From my understanding, we wouldn't start collecting revenue until we've given these people an opportunity to quit smoking, through 3 coaching sessions or something like that. So that's my first question I have.
As far as the tobacco surcharge, if we start that as of January 1, 2021, the additional premiums would be charged at that point. Our goal with this would be to put out a communication to all employees in advance of the start of this to give them time to try and quit smoking or do everything they can to understand what they would be expected to do come January 1. And that's really where the process is. So that would start as of January 1. Does that answer your question, Anthony?
So just for clarity, so what you're saying is their opportunity to quit smoking would be from August until January before the surcharge hit?
If the surcharge is approved, and then it's recommended by the superintendent to be part of the collective bargaining agreements, as long as the bargaining units agree to it, from there we would start advertising how it would work and when it would start. We would also give them some opportunities to quit smoking or anything along those lines. Have we fully developed it at this point? No, we haven't developed our full communication plan either. But we will develop that if you vote on it today.
Mark, I think for it to be compliant...
Mike, can you put the microphone in front of you?
Yeah, for it to be compliant, I think you have to allow for somebody that's enrolled in a cessation program to not be charged the surcharge. So I mean, I think
Oh.
Anthony's point is correct, that it is going to be a delayed revenue stream until somebody, falls out of it and fails to go through the cessation program. Now, those that obviously don't enroll, you could start charging them right away. But you're going to have a group of folks that are going to say, hey, I'm going to try to quit. So, I agree with you. I think it's going to be very delayed. And I would say we need to temper our expectations of how much money this is going to return, especially if we go towards an affidavit, which, listen, I'm trying to lose weight this year, but you wouldn't know it by what I ate on the way down, right? So, okay. So somebody can quit right before they enroll and say, I'm a non-smoker.
So at this point, are we just voting on the idea of following through with preparing, like you say, the opportunity to join a cessation program, the opportunity to start the communications and
Right.
develop the plan? Is that what
Yes.
we're voting on today?
That is correct.
Okay. All right. So does that sound okay to you, Anthony, as our union?
That gives me a little bit of pause, especially because we're putting a $50 to $100 a month, affidavit or saliva test. For instance, I would not agree
No,
to
that's
a
saliva
saliva test. So I would hate to come back, a month from now and there's a saliva test. So how can we work through those issues? I understand we don't want to get bogged down today. I think we want to be able to move forward, and I'm with everybody on that. But how do we kind of like tentatively approve something without?
We can certainly develop the plan. We'll have to make sure that we have it correct and it meets all of the federal guidelines. We wouldn't put anything in place unless it meets that guideline. So if there's a period of time we have to give people to quit, and if they don't quit, then start to charge them, we will follow that. And we will make sure that's appropriate, and we can report back to the SIAC committee on what we're doing and how we're doing it long before it starts.
So, Mark, can we make the change to the motion and say, just to go on and say that we're in favor of this program with the only affidavit part unless we learn otherwise with federal guidelines?
Those are other votes that we have on the agenda, Dawn. The first one is just to approve yes or no, do we want there to be a program of some kind?
I know, but Anthony's issue is he doesn't want to say yes if the possibility of having a saliva test is there. So I'm just taking that off the table, or suggesting that to come off the table.
Well, I think it depends on what the motion is from everybody on the committee.
I agree with removing the saliva test. Can we have a motion to,
Wait. Hang on to say it, because just the motion, as I understand it, is are we going to do it or not? And what's under there, if yes, the $50, we're going to vote separately on that, correct?
That would be
Is it 50 or
correct.
100? Are we going to do saliva test or affidavit? So we just need to move forward as a committee of, does the voting members of this committee think that we should do some kind of tobacco surcharge program to help our plan and get our
and
employees
then
moving towards a
line by
health?
line go through the rest?
Yes.
Okay, I see what you want to do.
We have more discussion. Please
sorry,
pull
go
that
ahead.
microphone in front of you.
As you've pointed out, this committee is to recommend to the superintendent, so I'd like for the committee to say what they feel is right. Bargaining is a secondary issue. I don't feel we should change our vote because a bargaining rep is sitting here.
Agreed.
Point taken.
Okay. Well, we can still take a vote. So let's our first vote be, we need a motion. Okay. Thank you, Chris.
Chris made the motion.
And a second, do we want to develop a tobacco surcharge program? And we have a second?
Second.
Okay. All in favor?
Do you need to go do a roll call with all the voting members?
Yes, we need to get a roll call vote from everybody.
Okay, well, there's only 2 voting members on the Zoom call, I believe. Ms. Butterfield, what is your vote?
I'm in favor. Aye.
Mr. Bailey?
Aye.
Okay. And
Where's Sheila? Wasn't Sheila going to call her?
Ms. Gaynor, are you on the call? I don't believe she is. Okay. All right, so I assume that is approved. So let's move on to this.
Well, let's take a vote in this room too.
We did.
And
All in favor in the
Well,
room?
no, if we could do it one at a time,
We need to do one at a time.
yes.
Okay.
It's just better that way.
You don't vote. You don't vote. Anthony?
Yes.
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 Yes. Yes.
Yes.
Yes.
Unanimous vote?
Yes.
All right.
All right, let's go to the second bullet point. We need to have discussion as to the amount of the surcharge and $50 a month and $100 a month. Is there any discussion or any points anybody has on that amount?
I would like to make a motion that it's $50 per month.
I second that.
Can we take a voice vote on that then?
Is there any other discussion on that before we move on to the vote? Anyone? Okay. Mr. Bailey, what is your vote? Jeff, can you hear me?
Aye.
Okay.
Yeah, I figured out how to mute it. Aye.
Okay, thank you. Okay, go ahead.
Yes.
We're going around the table.
Yes.
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 Yes. Yes.
Yes.
Yes. I feel like lemmings.
Another
Okay.
unanimous vote
Another
for
unanimous vote for
$50 per month?
$50.
Hi, excuse me. This is Nadia. Sheila's having some difficulties dialing in on the Zoom, but she does want me to say that she is voting yes.
Can we allow that? Ms. Gaynor, Sheila Gaynor? Yes? Yes. Thank you.
It's
Nadia.
11 on 50.
Okay.
You're welcome.
All right, third bullet point is by affidavit or by saliva test. I think Anthony's already made the point against the saliva test. Is there any other discussion for either of those options?
I make a motion to do the affidavit versus the saliva test.
Affidavit only, okay. Do we have a second to that motion? By Mike DeVoe. And we have a motion to go affidavit only. Ms. Butterfield, what is your vote?
Aye.
Mr. Bailey?
Aye.
Ms. Gaynor? Nadia, did she vote?
No, she hasn't sent me anything. I'm resending her the Zoom information and
Okay.
asking her to try to dial back in.
Okay. All right, let's go around the room. Anthony made the motion, so go ahead.
No.
Yes.
Yes.
Yes. Yes.
Yes.
Yes.
So we have, unless Sheila Gaynor, has she come on?
Yes, I do have a response from her. Her response is no.
Her response is no.
Okay, so we have 2 no's, the rest of the 11 total are yes.
9 yes, 2 no.
So at this point, it appears, I don't want to speak for anybody here, but
Rosemary, it's 2 no's on the affidavit, correct?
yes. 2 no's on the saliva.
Saliva wasn't.
2 no's on the saliva, the remaining 9 are yes on the saliva test.
No.
Affidavit.
9 of us said affidavit only.
I'm sorry, I said that wrong. I
Saliva is
apologize.
out.
Yeah, saliva is out. No saliva. Yeah.
There
It
you
got
go.
voted down 9 to 2.
It's gone, so it's an affidavit that this group is looking for.
Got voted
All
down
right,
to 2.
great.
Okay.
I think
All
we're
right.
done with that one.
We can move on to the physician designation.
On this, let me get back to the slide on that. On this, what we have talked about is the Signacare designated network. What this basically is a $20 surcharge for anybody who does not go to a Cigna designated care physician on our normal OAP plan. I've asked Brian McNeil to come up and give us some ideas of how that works and how that capacity would match our groups. So Brian?
Good afternoon, everyone. As Mark said, the CCD, and I think you've seen this exhibit in the past at prior meetings where we identified all of the current providers that are CCD designated within Cigna that your enrollees are currently utilizing today, and it came out to be 23.3% is the actual percentage. So there's 920 CCD providers now that you're utilizing that if they continue to go to them, you would keep, I guess, the same copay that you have today, Mark, is that right? the same lower copay that you have today. If you go to a non-CCD provider in the network, the copay to them would go up by an extra $20. So they can still go to whoever they want to. They just pick and choose at the time of service. And when you go onto myCigna.com into the app and you look for providers, it shows you which providers are the designated providers on the app, whether it's online or on your iPhone, or smartphone, I should say. Now, I just found out today of the 920 that you see here will go down to 905 for 2021. So that goes from a 23.3% down to 22.9%, so a slight reduction.
22.9% of what?
Of the providers using today will be CCD versus 23.3.
So all of our employees would have to go from the 100% of the doctors they're using now down to 22% of the doctors that are available?
If they want to keep, well, they don't have to go there, but if they want to keep the same copay that they have today, they would choose one of these 920 providers.
That's a 78% cut in the amount of physicians available that are currently being used?
No, I think what we're doing is trying to steer them through benefit, that if you want to pay the lower copay, you go online, you look at which are the better performing physicians in the network, and you take your child there, or you go there yourself.
I don't think that's possible. You couldn't get a doctor's appointment if you tried.
Well, that's a good point, because Mark asked me to look at the access to care, and we just did another, over the last few days, we've been reaching out to physicians. They do have the capacity.
Brian, how did you get that capacity? How did you guys
It's
figure
through a geo access capability through CCD versus non-CCD and outreach to the providers. So we don't see an access to care issue. You're not required to go there, but it does, that $20 differential will get someone's attention, and they will make the decision to change their behavior and possibly use a CCD provider.
Brian, could I ask a question? On the Excel spreadsheet you had that had the almost 9,000 providers, there was on the very right column, it said open access plus match. So if that said yes, does that mean that that doctor is eligible to become one of the CCD providers if they choose to?
Well, it's not that they choose to. Cigna looks at every provider's results for the year.
Okay.
And we look at clinical outcomes, cost of care, member satisfaction surveys, how often they see their patients in the office versus send them to the emergency room. There's a large criteria of information that we look at to show Cigna if this person would qualify to be a CCD provider, a designated care provider, which is the better performing physicians in our estimation in the network.
Okay.
And so, for instance, that 920 goes down to 905 for 2021 because 15 of those providers right now aren't going to qualify for 2021.
Okay. So there's nothing we can do to talk our doctors into being part of this except for just becoming better?
It's just their, absolute results.
I think that's the point. Brian, can you explain why this is beneficial to our plan?
Well, these physicians that we've identified have shown that they have the best clinical outcomes. They see their patients instead of sending them to the emergency room. They actually just have better clinical outcomes, hence lower cost of care. And we know that. They bring better value to our plan. So if we encourage members through a benefit selection of a lower copay, it will drive more members to at least consider a CCD provider when they're making that decision to have care.
So is the projected, one more thing, the projected savings that is up there of $690,000, is that a combination of the price differential for those who are not going to a CCD provider as well as the outcome reductions for redoing the same type of medical issue with a doctor because of their past history?
Correct, it's both. So we know it's going to steer people to the better performing physicians, and you're going to be charging $20 more that Brevard schools won't be paying.
I can't fathom how it is going to be physically possible for all 7,000 some odd employees to go down from 100% of the doctors available to 22% of the doctors.
Not 100%.
It's not possible.
Not 100% of the people are going to choose that. Some people won't change their doctor.
For a $20 differential, they will.
Brian, what kind of migration did you get? I'm sorry, Anthony.
Well, I was going to say a couple things. So first of all, I believe that most of this $690,000 is actually not savings. It's revenue from charging people more on the copays. As we considered the idea of the Cigna Care designated network, we were thinking about it a little differently. If the savings are real and actual savings, and this isn't just all revenue, we were thinking instead of jacking up the copays on those using the other doctors, why not make these lower copays in order to incentivize folks to go there rather than, shake a stick at them, so to speak. So instead of, a $30 copay to your primary care doctor, a $20 or $25 copay to a doctor in the care network. So
You could do that.
Is that a possibility?
I like
Yeah,
that
we-
idea better.
Yeah, you could do that, but we need at least a $20 differential for better behavioral change. So if you want to lower it to 25, then make it 45 for the non. If you go down to 20, then make it 40. Right, so you kind of give them a $10 differential if they go, and a $10 increase if they don't go. But it's still a $20 differential.
I have two questions about the how you all analyze it. Is the criteria published anywhere, or can you tell us exactly where you all go to get that information? And in terms of paying the doctors, do you all pay those doctors less than the other doctors, or is that part of this savings also?
No, it's the first part of your question is I can try to see if I can get what our formula is. It's not something that's published. It's Cigna uses the data internally to decide who we should offer the CCD to or not. As far as the actual cost, it's that we pay the doctors the exact same reimbursement rate as all the other doctors in the network. They just perform better, so their medical costs are lower. That's how you get the savings.
Okay.
There's another question.
I'm sorry. Go ahead.
Can you pull that microphone just
Real close.
in front of you?
My question is, we're looking at that number of people, if we're steering them to those doctors, what other groups in this county are also going to be steering their employees to those doctors, which is then going to
That much harder
overload
to get
those
in.
doctors, and how do our folks get in if other groups within our county are also going to be trying to get into those doctors?
Well, right now, in my book of business, the only two accounts that I have is this account and Brevard Government across the street, and they do not have CCD today. They may also adopt that going forward. I don't know if they will.
What about Harris Corporation?
I'm not sure. It's a national account. I can ask that client
Yeah,
manager.
my daughter.
Like Harris, BCSO, all the big ones are all Cigna and all have the designated care networks. And you're right. Your point is well taken. So are we at the point where we've had discussion?
Dominic has a-
Go ahead,
looks like
go ahead,
Dominic.
Anthony. I'm sorry.
Dominic was first.
Who was first? I'm sorry.
I'm looking at page 16 on the slides, and where we look down at steward providers, we got 344 providers for their hospital system, 0 being used by BPS employees right now. How do we get quality on these providers?
Okay, what was the question again, Dominic? I'm sorry.
Okay, down at the bottom there, where you got
Yep.
steward providers,
Yes.
bottom left, 344,
Yes.
and we don't have any BPS employees utilizing them. So
Yeah.
if they're in this network due to quality aspects.
Well, this isn't the CCD. The steward's not, the steward and the items at the bottom is something different that Mark wanted to utilize for the alternative network. So CCD has nothing to do with the information at the bottom of the sheet. The CCD is only the upper portion.
The alternate.
Yeah.
You're right.
Is that because Stewart is relatively new in the district as an organization? We just don't have statistics yet? Could that be?
Not many people use them.
Yeah. Because Stewart is what?
The old Wusthof system?
Rockledge Regional, they call it now, Melbourne Regional, and then somebody in Satellite Beach or something like that?
Yes, Satellite Beach,
Sebastian, that's what it is. Okay. Only something.
Actually, there are, just to let you know, there are, Steward hospitals are located in 17 different states. When Brian ran this, I don't think you found enough doctors on Steward's network to allow it to be, if we choose the alternate network, there wasn't enough doctors to really support that. Is that correct, Brian?
To support CCD?
Yes.
Yeah, CCD is only in our large, broad network capability. It's not going to be on a client.
So it'd only be
network.
for the OAP plan.
Yeah, correct.
Okay, let's go back to
Anthony
the
has a question.
CCD. Go ahead, Anthony.
So currently, the primary care office visit is $30. Are you saying if we did the designated care network, we could charge $10 for a primary care visit and still come out saving money?
You would steer people towards those providers, and they would still pay the same. I'd have to have the underwriter, he modeled it as copay staying as it is and charging the higher, so they have to have the underwriter model that out at the lower copay versus what we modeled out.
We didn't put that model together, so I think if this is something that we need to do that, and I would recommend that we not move forward with it if we have to model it that way until we actually see what the pricing comes back at and how it would affect the trust.
So should we table that discussion for a future meeting?
Yes.
Okay. I would like to see those numbers. I agree with Anthony. I like the idea of, instead of charging more, giving an incentive to go to the CCD providers by charging $5, $10 less of a copay. So if we could get statistical data on that, I think that would be.
Anthony has
Go ahead,
something
Anthony.
else.
I was just going to say, I think that would be prudent as well, because we're possibly looking at adjusting some of the co-pays to begin with, so
Right.
we wouldn't know where to.
I
move
think
them.
we got to look at this thing conceptually, because the reality is we're going to do plan design changes, and we're going to have to target events that have high frequency, which is going to be copays. So I think we look at it conceptually and say, does the idea of having, designated physicians with a $20 differential, what that differential, starts with, I think that's open for discussion, but I think we need to look at it and say, does this concept make sense to bring forward? And then where do the copays fall? I think we've got to hash that out.
That's
too.
exactly what I was thinking when I immediately saw this and said, wait a minute, we're already going to have to increase. Why would we add $20
Yeah.
more? That seems cruel. So I like the idea of knowing we are going to have to increase, maybe looking at an incentive to lower for going to a CCD.
Or keeping it where it is, and then the
And the
non
others
goes
go
up.
up.
I mean, those are things we all got to hash out, because we got to get, we got a $3.5 million number we got to handle.
Might I suggest that we wait on that issue until after
Okay.
we talk about plan designs and then come back to that?
I agree. Let's table number 2 for now, and are we ready?
Real quick, one last question. Do
Yes.
we have the list of the CCD or CCN doctors?
Yes, we sent those out, or I sent those out to you
All right,
last
sorry.
week.
No problem. Okay, thanks.
All right, let's move on to spousal surge charge and the dependent audit.
Let me go back, pull these slides back.
Don't we do that anyway? Is that not normally done every year?
Nope.
What is that?
We did it that first year.
Which part, Don?
Both. The audit of the dependents and the spousal.
All I was going to do
surcharge.
here is just advise everyone that we are doing a spouse and dependent audit now. There is no vote taken on here, on these items. We expect to have that back probably by the start of the school year. Hopefully, it depends on how our reach out is during the summer to reach people to obtain that information. But as soon as that's done, we'll be able to provide that to you and let you know what kind of savings we can get by taking people off the plan or making sure they're in the proper plans based on their family makeup. So that's coming. In addition to
So
that,
we don't look at that now? I mean, I'm just.
That data hasn't been gathered yet.
well, let me clarify that. We do have a spousal surcharge. And what that means is anybody in an employee spouse plan, well, no, not on that plan. On the family plan itself, if their spouse has the ability to get health insurance elsewhere, they pay a $250 per month premium increase if they wish to stay on our plan. We have about 800 or so, I think, is that correct, Lisa, that number, about 800 that currently have that plan, and we have 23 people that are saying that their spouse needs to pay that, or that there's a surcharge for it. So we do believe that there might be some findings that we can get from that. In addition, this is looking at dependents as well. So I think we're fairly accurate when it comes to, well, I know we're pretty accurate when it comes to dependents on the plan. The thing we would be looking for is if there has been divorces over the past few years, because the last time we did a spousal audit was about 5 years ago. And if there's divorces that have taken place and the employees are still covering children that are not their own children, that's who we would be looking to remove from the plan, which should save us some dollars as well. So all of that's figured into this audit.
How does that work in a situation where a divorce decree mandates somebody continue to cover a child, even if it's a stepchild or something like that?
A divorce decree would apply to that employee. It doesn't apply to the plan. We are not required to cover those dependents. They would have the legal obligation to buy that insurance for those children. But we wouldn't be, if they are not a child of an employee, we're not required to cover them.
Go ahead, Anthony.
Mark, did the vendor that we chose to do this give us a guaranteed, I remember looking at several different options. Was this a guaranteed return on investment?
There was a guarantee. The vendor chosen, we're paying $22,500 upfront. And if they don't get a savings on the back, then we don't have to pay the rest of the $22,500 that's due for the audit. And there is some additional savings on that. I don't have that in front of me, and I wish Lucianne was on the phone who could explain that, but there is a guarantee. So it would be reduced from the $22,500 as well. So that's information on that. Currently, to the next item, RSM McGladrey is doing an audit on our well care centers to see if they are reaching the ROI that's been promised to us at this point in the contract. As soon as they are completed with that audit, we will bring those results back to you, and we can go from there on discussing the clinics itself.
We are moving on to plan design recommendations.
All right. I do want to start, before I turn this over to Amanda Brooke, to talk about just a couple of things. If you go to the last slide on the handout that I provided you, you've seen this before. I do want to remind you what Aon's projections are. And I wish I had a pointer to point this out, but I don't.
Are you looking at page 18?
Yes, if you look at page 18, and hold on. I'm just going to grab the mic and come up here and point out some things that I think are important for today's discussion. Last week, we had a discussion on what our projected shortfall was. Now, there was dispute as to what that is, and I'm fine with whatever you believe it is. But what Aon is projecting is that by December of 2021, we will be in the red on our health insurance trust fund by $12.7 million. Currently, we have, through March, April has not closed at this point. Our April trust fund balance is about $7.8 million. Now, we do expect, and there's people in this room that know because they work in hospitals, we do know that April, most of the hospitals were closed down to elective surgeries. So we are expecting that we will have a surplus for April, possibly for May, and it could continue. We will have to see what happens. So that number could change. Another thing I want to point out is by the end of this year, 2020, that $1.1 million is what's expected in our trust fund. Now, if we get some savings in April and May and June, that could be higher based on what's happening due to COVID-19. What we don't know at this point is, are anybody being treated for COVID-19, which could be part of those costs as well. But I think it's important for me to point out that's where we're headed if we do nothing when it comes to plan design today. We don't know where the premiums are. That's something that has to be decided at a later time. But we do know that next year we're either going to be at 12.7, which is what Aon projects in the red, or we'll be at 10.5, which is what I heard last week from people in this room. And so that's why on the things we're going to talk about today, you will see $10.5 million as the projection as of December 31st, 2021. I want you to think about this. Whatever changes that are decided today, whether plan design or anything else, if we look at what we need to have, this is 12.7 in the red. We need a 60-day trust fund in order to be healthy for the Office of Insurance Regulation. That amount currently is $11.6 million. So if you add the $11.6 million to the 12.7 or the 10.5, if that's what you wish to use, you'll see that our shortfall to have a plan that passes the Office of Insurance Regulation is about $20 million. I cannot speak for the board, but I don't think we have that kind of money to fix this on premiums alone. We've got to look at plan design, and it has to be something that we work out with a give and take on plan design as well as premiums. I don't have any information on premiums today, but I think it's important that we look at plan design, because if we expect it to be all premiums, we're just not going to get there. Does that make sense?
No.
Okay.
Well, something I want to bring up too is you've seen in the news the last couple of days about superintendents from all over the country petitioning their legislators for infusions of billions of dollars into school systems for these sorts of situations. Has our superintendent gotten involved with that? Is our district trying to ask for some of that money? How can that money be brought back into our district as well to help
When you say
remedy?
For these sorts of situations, you're talking
Mhm.
about medical trust fund files?
We-
I will tell you that when it comes to the funding string, the
Mhm.
strings that are, and Mrs. Cincy can confirm or, what I'm saying, those kinds, the money that we're expecting to receive, that Brevard County should, we already expecting to receive some, those aren't for things that we already knew were coming and we had to do with. Those are for expenses that we've had to have because of, like, we haven't had Brevard aftercare funding coming in, but we've continued to pay those people. We've had extra custodial expenses and those kinds of things. It's not going to be a situation that we already found ourselves in before coronavirus ever hit. I just don't think that's what it's gonna come towards. It could be because of reduced enrollment, things like that, but I just don't think this kind of expense is going to be what that money is dog-eared for, and it definitely will have a label on it.
She's absolutely correct. The funding that would come from the federal government is to pay for employees that weren't getting paid. It's in order to pay for costs because of COVID, right? The expenses that we've had. And it's also to make sure that, in the thing that is most important in education, is make sure that kids get a great education to be able to stand up to schools again next year. We don't know what they're going to look like, but all that funding is to help us mediate or to be able to cover the costs that are going to become because of COVID. Not
And I
because I believe the health plan, this has been a 6-year problem. This is, it's not, the funding is not to fix our health care.
And I understand that for the money that's coming from the federal government to cover COVID-19 for salaries and things like that that have been reimbursed. However, there is another movement going on in the country to ask federal legislators for money to cover deficits from the last 10, 15 years, like this.
The only thing that
Because, years ago, and Anthony, you can remind me of exact years when educational funding was cut dramatically, those kind of things are catching up with us now, and we see them here. And superintendents are petitioning federal legislators asking for money to make up for that money, nothing to do with COVID-19.
I would say this. We don't have any information on that. And from my view, of course, I'm not a voting member in this committee, but unless we know what's going to happen, we're going to have a shortfall. Whether people in this room believe it's 12 million in the red December of next year or not, we're going to have a shortfall. The hope is today that we can look at some plan designs and come away with some ways that could apply towards that deficit. Because I just don't believe that premiums alone can fix this problem. And that's why it's important that we take this serious today, because, premiums could resolve it all, but we just don't have enough in revenue to cover that type of a premium. Does that make sense?
It does.
Okay.
But not knowing how much that premium change is going to be is going to impair our ability to know how much plan design to make. Does that make sense?
Well, I think the reality is I understand this is a passionate issue for everybody because nobody likes the benefits changing, but I agree, this is a 6-year problem. We have sat stagnant and complacent, and we have been lucky. We have been lucky that our claims have been favorable over the 4 years that I've sat here. But the reality is there's no plan that stays as stagnant as this plan stayed from both a premium funding standpoint and from a plan design standpoint. You know, I'm on TRICARE, which has a heck of a lot more members, and we change our premiums and we change our plan design every single year. And I think this is just a reality that we've got to do something with this plan. What we came away from last meeting was we're going to do this incrementally. We're going to assume some of it's going to come from board contributions, some of it's going to come from employee contributions, and what we're here to solve today is some of it's going to come from plan design. So I think we just need to roll up our sleeves and decide what is palatable from a member perspective, you know, and what is the fair distribution? Because your healthy people are going to say, take it off from plan design because I'm not using the plan. And your unhealthy people are going to say, no, take it from premiums, or the board must come up with it. But we've got to, I think we got to divide this thing up and come away with some recommendations that gets to that $3.5 million number.
Mike, I agree with what you're saying, but if
Just
you
a second,
look,
Don.
if you look at scenario 2, they are taking premium payments to solve the problem, all from the employees. It's entirely from the employees. And Mark, when you were asking, does this make sense? I was saying no, because we're looking at charging people 47% more and at the same time potentially reducing their benefits. And now if I agreed to everything on scenario 1 and it said $3.5 million, well, where are we getting the other $7 million from?
And I hear what you're saying. I would rather focus on what I think the charter of this body is to come forward with the plan design recommendations. We're not here to solve the employee contributions, are we?
Well,
is that our charter, Mark?
Well, money's got to come from somewhere.
The second scenario is if we add the alternate network. And let me speak to that real quick. That alternate network we're going to talk about next, because what that would allow us to do is to bring in 2 hospital systems that are costing us much less than the majority hospital system for the employees that we have working for us now. About 80% of our employees go to the Health First Hospital Network. Health First is a fine hospital system. Everybody likes them. That's why 80% of our employees go there. The problem is their rates are nearly double what you see from the other 2 hospital systems. The reason why we added that scenario is to encourage people to move to the alternate network. Now, you encourage that by increasing the premium if they wish to continue with that plan. But what that does is it gives them a chance to look at an alternate arrangement and decide financially, is it worth going with the OAP plan that includes Health First, the extra dollars I'm paying per month, or should I consider the alternate network? That's really what it is.
Mark, and my concern on that one is and I haven't looked at, but that excludes a portion of the county, correct? That doesn't have access. So if we, you know, to me, you do that when it's equitable and everybody has the same equal opportunity to select that network and make that financial decision. But if there's an area of the county that doesn't have access to those providers, that concerns me a little bit, because it's not, you know, they're going to have people that say, I could do that, but then I got to drive 50 minutes to go see a provider. So, you know, to me, that one, I struggle with that one as an option.
Well, here's the reality on that one. If there is an emergency, it's a life-threatening emergency, they aren't charged additional premium.
I get the emergency side of it. I mean, that applies if you're in, you know, California too. So I'm looking at real, you know, day-to-day care here. Is that, you know?
It is true we only have 1 hospital in Palm Bay, but there is a hospital in Sebastian, which is not too far out of the county line. But we also have a Stewart Hospital in Melbourne that's close to Ellis. We have Rockledge Regional here, and we have Parrish in Titusville. So I think there is good coverage. When I've talked to both of those hospitals, you know, everybody I've talked to, there is a lot of physicians. And I didn't want to jump the gun on that, but we got into that discussion. I just needed to clarify where there's a pricing difference. But there is more physicians on that list than what Brian had provided us with. Chris alone told me that they have over 500 doctors that that have privileges at their hospital. So there is plenty of physicians. But instead of jumping the gun on that, I wanted to give that as a second alternative. The first thing that I think we need to really talk about now is what we do with our existing plan.
Can we pause for just a moment? Ms. Butterfield asked to be recognized.
Yeah, and because it's hard to kind of just go, because I was listening and y'all were talking about 13.7 and 2 million or whatever, and so I went back to the assumptions, and back to what my industry is in pharmacy, and I went back to Express Scripts, which is now Cigna, and I went to their last year's trend report on drug cost. And Brian, do you know what that is?
He said no.
Putting you on the spot. Okay, it's 2%. So if now what is supposed to happen between a insurer and PBM and things are supposed to be more cost effective and all that, I think a 6.4% and 6.9% for pharmacy. Plus, I sent you guys a list of all of the drugs that are going generic. I think that we are way overestimating. Plus, we really haven't, again, dived into a lot of that. So I think that part, if we could, factor that down to, split the difference, maybe say 3%, I think that number is very high.
Okay, but what we're talking about today is $3.5 million. We're not talking about little bits here and there, and one more rabbit trail for this committee. I'm sorry, I'm going to get off just a second. One more rabbit trail for this committee to chase. We can't do that. We're talking about $3.5 million. And even if there's pharmacy savings to be had, and even if there's this to be had and that to be had, I think we're talking about a $10.5 to $13 million. Even if you don't agree with those numbers, today we've got to get $3.5 million. And if we find more savings other places, hallelujah. Maybe we can give our employees a premium break. Maybe like Cigna gives us. Maybe we can do other things that would benefit our employees. But we've got to come up with this $3.5 million. Even if there's all these.
Okay, so just changing that for 1 year is $500,000. Is what I'm saying.
Well, we could use that $500,000. We could definitely use that $500,000.
Okay.
In addition
That's
to
what
the
I'm saying.
$3.5 million.
Change. Okay. So there's out of 3.5, there's 500 right there.
Well, I mean, these things.
So
I think,
I am looking at that, Katie, as part of the thing. That's what I'm trying to bring up. Is it's not doom and gloom on pharmacy like they're saying on the 6.4. So that's almost $500,000 per year, per year difference.
But if you look at the plans that are recommended, there's no change in our pharmacy copays that are recommended in this new plan.
It's not. I'm talking about trend in what the PBMs have had over the. They always do these reports every year, and they talk about drug spend because they like to brag, that they're better than the other PBM. Well, the PBM that we have now, which is Cigna, bought Express Scripts, and Express Scripts trend last year was 2%. In fact, they said that 40% of the plans, actually the numbers went down, I think. So I'm saying that those are Aon numbers, so I'm not sure that is what we want to use. And if we're talking $500,000, then we're a third, well, whatever.
But we're not using Aon numbers. We're not using the 13.7. We're using 10.5 that this committee arbitrarily came up with last week.
Let me say this, and I did not bring this slide with me. But if you recall, I think it was in the last meeting, it might have been the meeting before, we went over our medical costs over the past 6 years and the pharmacy trend. Pharmacy has been flat. So I do not believe that has been a portion of what this trend is from. The trend is coming from medical costs. And that's why we're here today, is to address some of those medical trends, not the pharmacy trend. So that's why.
Okay, so narrowing to the hospitals, you say, could possibly be half, and then they added the increase in pharmacy, so we could take that out. I just don't think we're in as bad shape as it looks like.
And Dawn, I think that's why at our last meeting we agreed not to go after the $25 million and negotiated it down to the $3.5 million that we are trying to target through plan change.
Let me say one more thing, and then we will pull ABK up here and she can give her assumptions. The reason why I had the bubble chart, Ann calls it the bubble chart, is it gives you an idea of how many people would be affected by changes to plan design. And from this chart, you can see that a very small percentage are costing the plan in medical and pharmacy combined in excess of $25,000 a year. Most of our employees will not be affected by any plan design changes. Now, obviously, if there's an increase in copay for especially in CP and PCP, there is, but for the major costs, they just aren't there from what's been showing here on this bubble chart. But I'd like to bring Amanda Brooke to come up so she can talk about where she found and placed the $3.5 million in savings. Once she does those assumptions, if anybody here wishes to look or make different changes to any one of those areas, she has the ability to run that today.
Good.
So we can get an idea of what you would be willing to consider as far as changing the plan design. So Amanda, I'll let you take it.
Thank you all. And just a side comment, I don't know if I'll get the response to this question before the end of the meeting. I'm hoping so. In last week's SIAC meeting, we provided you with a chart that showed the volatility of the claims trend over time. That was medical and pharmacy combined. But I have requested if we can isolate quickly the pharmacy trend alone. I believe it has similar volatility, but I don't know that for certain. So I just want that to keep in mind in perspective to your group and the potential volatility for the group of your size of the volatility around trend. So just a quick comment on that piece. Mark, would you like me to provide some additional commentary on this slide? Okay.
You certainly can.
Just, I think it's important as a reminder before we get into any of the plan design scenarios. When you're thinking about increasing deductibles and out-of-pocket maximums, absolutely that is going to impact some of your employees. And we fully understand that. But this is a slide I know you've seen before, but we thought it was important to bring this back briefly to just point out that for the first bullet, saying that 4.5% of your claimants, so that's your total membership, 4.5% of your membership account for almost 53% of all claims greater than 25,000. So it is a very small portion of your membership that does have high claimants. We have just over 40% of your membership that their claims do not exceed $1,000. There certainly are people that fall in the middle of that. Changes to deductible will impact those people, certainly, but just wanted to give you some perspective on the portions of your population that could be potentially impacted. And again, based on historical prior 2 years, very consistent data over the prior 2 years of people that are falling into those into the multiple categories here. Okay, so you're saying I need to use the mouse, my computer? Okay. Okay, so we do have 2 scenarios that we're bringing to you today with a target of $3.5 million of plan design change savings. In this first scenario, it's continuing to offer one plan, a PPO plan with plan design changes that equate to the $3.5 million. And your note, as we've had conversations already today, we are comparing this to, we've labeled it here as SIAC member estimated 2021 shortfall of $10.5 million, so that the remainder would be a $7 million. And also to orient that again, whether we're talking about 10.5 or 13.7, we're referring to the projected loss for 2021, meaning the revenue versus the expenses of that individual year. So it's not addressing specifically the shortage to the fund balance requirement by the state, which is a greater number. So I just want to reemphasize that particular piece. Since those numbers are so small on the screen, I'm going to refer to my hard copy here. So you'll see in this case, obviously, since our target is $3.5 million, not $13.7 million today, the increases are not as significant as you saw last week. We do have increases to the deductible, essentially increases across the board, increases to deductible, increases to the out-of-pocket maximum, increases to primary care, so going from $30 to $45, specialist to $90, preferred health center stays in line with the primary care at $45, the hospital inpatient copay portion increasing from $600 to $900. Similar for ER is going from $300 up to $450, and the separate pharmacy deductible is also increasing as well. We're not to that stage yet, but I do want to point out that this was one scenario that we came up with that it essentially touches all of the benefits. So you're seeing deductible changes, you're seeing copay changes across the board. We do have another scenario built in that if we get into the modeling later, that if you prefer to see less change to copay and more change to deductible, that can still get you to the $3.5 million. We do have that scenario built. It's just a matter of the preferences of the SIAC committee on that piece. And of course, we are not illustrating any changes to employee contributions or board contributions in this scenario. Any questions on this page? Sure.
So can you go through, I know we have this bubble chart on the other page, but how many individuals would be impacted by the annual deductible increase and the out-of-pocket maximum increase?
I do not have that information with me today. I'm not sure. I know, Nadia, you're on the phone, if that's something that you would be able to figure out. His question, if you heard it, and I'll repeat it and tell me if I'm incorrect. With the changes to the increase in deductible, how many additional employees would be impacted by essentially the $750 increase to the deductible?
And then the same for the out-of-pocket max.
And then the same question for the out-of-pocket max going from $4,500 to $5,500. Just generally speaking, I'm trying to look quickly. So right now you have 13.5% of your population between 25 and 5,000. Now, what portion of that is at 2,500 versus 49.99?
Hey, BK, I came up with about 520. I mean, you got about 7.9% that are in that area between, 1,000 to 2,500. So, in that band, I figured the majority of those, because you're going to, obviously the further you go up in that deductible, that percentage is going to drop off, just as it does in our utilization. So I would say it's probably somewhere in the neighborhood of 500.
Okay, but we do have additional data by a member basis in order to create this bubble chart. So if I know Nadia is listening, I don't know if she can do it before the end of the meeting, but if not, we can also provide that information.
Are we discussing this whole design change now, or just specific questions for?
You can, at this point, if you have questions or want, or whether you like or dislike this, that's fine. We can have discussions on that. If you want to see a different scenario, this is the time. We put 115 minutes towards this, so we can look at anything you want.
Can we add the alternate plan recommendation? Because if you look at scenario 2, that includes the alternate network plan, if we could have that in front of us as well to see what that alternate network looks like.
Yes, I think it might be helpful to look at scenario 2 before we start
Yeah.
to look at modeling.
Exactly. I'd like to put all our ducks on the table, and, all our cards on the table.
Not in a row, but on the table.
Might I make a suggestion then? Let's talk about the alternate network first and then take a vote. Do you want to consider the alternate network or not?
I want to see it.
Well, and I'm saying that, but I think that's probably the first thing to know, whether it's something we want to pursue. If not, then we can focus the rest of that on the.
Yeah, I think we should decide whether or not that's going to be an option before we move forward with our shuffling around of the plan.
Okay.
Can we ask some more questions about the alternate network?
Sure.
Yeah, that's why I say I think we should hash that out first and then go back to amending the plan so that we know what we're working with.
Let me say something here, and I've asked Brian to also be available, so you may want to come up next to the microphone. I think I indicated to you earlier the reason why And I absolutely believe this. Health First is a fine hospital system. They are. They're a great hospital system. They have situated themselves very nicely, so everybody coming off the beach side, off Merritt Island, they're going to go to those hospitals. So that in and of itself is what drives a lot of the people to their hospitals. They're the only hospital in Palm Bay, so a lot of people will go to that hospital for that reason. But they also know that. They also know that 80% of our employees go to the Health First network. A week ago, this past Monday, I had a conversation with the CFO, their vice president of managed care, and I can't remember the other gentleman. And we had talked about discounting, because we had one time had talked about the SureFit program, and I think most of you have heard that before. And we asked, would you be willing to take the 10% cut that has to happen to come into SureFit? And they indicated that at present, with 80% of our employees going to their hospitals, they can't make that work from a discount perspective, and they generate the revenue that they are currently getting. The 10% sounds like a flat 10%, but to be in SureFit, it really turns out to be about a 24% cut. And what they offered to us was a 3.5% cut. They're not willing to look at more than that unless, for our retirees, they add an additional Medicare option that could be offered to our employees to make that work. Well, when you look at those numbers, about half of our retirees are currently with Health First Medicare options and plans. So my personal feeling is that won't be there for the SureFit network. So really the option, and frankly what I told them during that meeting was the only option, if we can only get, and I appreciate the 3.5% reduction because I think that's great, but it doesn't give us enough to really curb where we're at from a cost perspective on hospitals to our plan. I think the Parish network is a fine network. We have a great representative here that could talk about how great his network is. And I think the Steward network is making some great strides. And I think what's nice about the alternate network that we're talking about is, I think, Chris, where do your doctors, where are they now? They go all the way up, even out of the state at this point, right?
Actually, we're as far north as DeLand, New Smyrna, Edgewater, all the way down to Palm Bay, South Palm Bay. I did actually send an update on our provider directory as of, I think it was yesterday that I sent it in. Because within county, we have 500 providers in county, but when we count our relationship with Nemours, Mayo, and Halifax, that number goes up more like 2,500 to 2,600 providers total.
That was my question. With this narrower network, how are we with specialists beyond just well care, normal stuff? You know, if, God forbid, you get a catastrophic illness, a disease, whatever, are we still well covered cancer care and, you know, catastrophic injury and things like that?
Yes, I would say yes to that. And the reason why I say that is when Brian ran the numbers, and you saw them on that one slide that has that on the bottom, you see 51 physicians for Parish, and you see 344 for Steward. Those are physicians that are directly paid by those hospital systems. That doesn't include the physicians that are not paid for them directly, but they have rights to those hospitals. So when you add those numbers to it, there is an awful lot of physicians that are available throughout this area outside of the county. Steward has hospitals in 17, and physicians in 17 different states. So they're available in multiple locations throughout the country. So I absolutely believe that there are sufficient doctors to work that network. It's just the idea of us getting the communication out to those who may choose the option of an alternate network. Yes, Dominic?
Okay, since we've started off with such a big donut hole to fill, last time I was in a meeting, it was like 12.5 million, then it went up to 13. Now we're talking about 10.5 million hole to fill. I think everything needs to be on the table, and we had put in the original RFP in the discussions in January 2019 the ability to do direct contracting with the hospitals. In your conversations with any of the hospitals, did you offer a direct contract?
Yes, we did.
SureFit is going through Cigna.
Yeah, it's a Cigna program.
Okay, now we're talking direct contracting with Brevard Public Schools to the hospital,
You mean without Cigna involved?
without Cigna involved.
Well, Cigna would be the conduit for this, but it is a client-specific network between Parish and Steward hospitals.
I'm talking about your direct contact with Health First, because in the RFP, we made sure we had the opportunity to go direct contracted to any local provider we could to obtain better savings. I'm just trying to exhaust all opportunities. Has that been exhausted?
Have I communicated with them regarding a direct contract? No.
Correct.
I did ask them what kind of savings they would give us, and they said they would give us a 3.5% savings.
Again, that was, okay, I'll go ahead and table that for now, and we'll take that one up later. When we talk about a local network, alternate network, I think we need to focus on just Brevard County and maybe into the Orlando area. We're trying to create as much savings as possible with that local network. We're not trying to mirror image something that looks almost like Cigna's OAP. So a regional type of network that creates better savings is probably what we're looking for on that alternate network. So if we were to limit just Steward and Parish physicians exclusively, would that provide us with greater discounts in that alternate network?
I suppose that anything is possible, but how would we, with my current staffing situation, how would we run those claims, Dominic? That's the biggest question we would have.
Okay, on that one, that involves Cigna SureFit, just trying to keep it local to try to create the maximum amount of savings.
I can give you an idea. I don't know if this answers your question, but when I looked at hospital pricing last year for the Steward, they were more than 100% less than what we're in pricing for inpatient and outpatient compared to Health First hospitals. And that's through the Cigna networks. That's
Okay.
with the OAP plan. This is a direct contract, and we would, Brian, we would be communicating with them to see if we can get additional discounts. Are we not?
Yeah, to answer your question, we can put in your client-specific network any number of physicians that you want. If you want to make it Brevard County only physicians for the Parish Health System and also Steward, we can do that. Or as Chris said, maybe include others that are outside of the county area so you have a little bit better coverage. But we can make it as large or as small as you want. But even with the larger network, it's going to be priced 10% lower. So anyone in that network that uses those facilities, if it's say is 20% of the enrollees or 50% of the enrollees, whatever, go into that network, it should save 10% on those enrollees over what you're paying today for them.
So not only do we have, the expected reductions currently, but we get a 10% additional reduction.
That's
Anthony,
for
go
the
ahead.
employee
You've been trying
and
to-
for the plan, right?
Pardon me?
That's for the employee and for the plan?
It depends on how you price it, but you could keep the premiums the same for them and then maybe charge more for the buyout, the plan you're in today as an option.
Can we back up just a minute? Because I know we've got lots of people watching this meeting, and just clarify, and this is for me too, I think I know the answer, but just so we can get it out loud. When we talk about the alternate network plan, are we really just talking about hospital benefits? Are we talking about doctor visits as well?
It's the physicians and the hospitals that are affiliated or have admitting privileges to those hospitals.
Okay.
Yeah.
Okay.
Go ahead, Anthony.
So when we began to talk about an alternate network, it started with the idea of this was going to be a free or low-cost plan to employees. That is not what this plan is right here. This is the same cost with fewer benefits to employees. Some of what Dominic is saying is something what we've been saying all along. This cannot be a rushed effort to go into an alternate network. This is a rushed effort. He just brought up something that's very valid and it's going to take some time to look into. And then on top of that, I mean, we can't have a network that doesn't have where our employees go 80% of the time. I mean, it's just unworkable. And I think there's probably other people in this room that are not going to agree to this without Health First being a part of the network. And I'm afraid we're just going to be wasting our time.
Mm-hmm.
Now, if this narrow network was a low-cost option,
Mm-hmm.
that would be different, but it's not. And once again, I'm skeptical of savings when it looks like a substantial amount is coming from generating revenue by jacking up the premiums 47% on people who stayed in the OAP plan.
You've said that several times. I think the point of savings is savings to the plan. That's what we're trying to do right now, is savings to the plan.
Well, there's savings and then there's generating revenue.
But all of it is about the plan, the bottom line of the plan.
Yeah. Hey, I'm just going to throw my 2 cents in here. I think the time for vetting, solutions that are going to take time, we've got to figure out how to handle $3.5 million in a recommendation, because this can has been kicked down the road for 6 years. I think we're done kicking the can, at least for a portion of this. We've got to come forward with some recommendations that are going to have impact now. I don't want to say that we don't need to evaluate the pharmacy. I don't want to say we shouldn't continue to have discussions on direct contracting. But again, those things take time, and we've got to make a recommendation by the end of May. Is that?
That is correct.
Okay, so we've got to come away with some savings on the plan that we can count. And that's going to come from events that have frequencies to them, deductibles, out-of-pocket maximums, and copays.
So if I'm looking at scenario 2 correctly, if the alternative network is put in as an option, an employee only, for example, would maintain their same rate of contribution. And if they chose to stay with their current situation, the current Cigna OAP, they would have a 47% raise in their employee contribution per month.
If they wanted access to Health First
If they wanted access to Health First hospitals.
Right, yeah, that is correct.
So to stay the same, basically, across the board, right? Is it across the board? I didn't check. Yeah, to stay the same across the board with no premium increase, you would have to choose that alternative network.
Yeah, and I think that's steep,
Is that what I'm
Amy.
saying?
I would agree with you. I think 46% is a steep
That's
jump.
too much. Go ahead, Anthony. Sharing microphone.
So, Mike, to respond to what you're saying, okay, it is May 7th. It is May 7th. We need to come up with this by the end of May. We don't even have a list of doctors. How can we be asked to consider an alternate network when we don't have a list of doctors? I had a list, and I mean, it is not a lot of doctors on that list. And Mark's saying, well, I got some more doctors, and really, where are they? Where is that list? I cannot agree to a plan when we don't even have a list of doctors. So that's my concern. Yeah, I agree.
I agree with you on the alternate network, but at some level, maybe we need to talk about the plan design changes to the current OAP plan and come away with those today, so at least we can push those forward to the board and maybe give ourselves some breathing room to vet some of these alternate solutions.
So can I recommend that we have discussions concerning scenario 1 only today? Alternate network just be tabled until a future meeting until we have those lists of doctors?
If that's what you wish to table, the alternate network, we can certainly do that.
At least for another week until we can get more information, and then, like Mike recommended, try to come to some consensus of changes under Plan 1 only, scenario 1 only.
Leslie had her.
I'm sorry, Leslie.
That's okay. Let's look at the bubble chart from a different perspective. You know, your healthy people pay for your sick people. Our Health First people cost more to the plan because those doctors are more expensive. An alternate network would save the plan money in a different way. You know, for those that do choose to go to Parish, it can help the plan. For those that choose to go to the more expensive Health First, that costs the plan more, it needs to cost them a little bit more.
A little bit more.
People are not
Yes.
going to like that I've made that statement, but too bad.
No, a little bit more, yes. 47% more?
Patrick has some.
You have to speak into the mic because we're on the Zoom call.
Has there been a detailed analysis on the disruption to the plan with the changes that we're proposing?
Maybe Kay?
Disruption analysis.
What is the disruption analysis?
Disruption to the employees.
Well, I think what you could say is anybody who goes to the alternate network Well, 80% of our current employees are using a Health First physician and the Health First network.
So there'll be huge disruption.
There would be a lot
80%
of
disruption, 80% disruption
Huge.
is what.
And my fear with that 80%, we're not talking about kids just going for their annual checkups. I'm thinking of people who have complicated medical situations, switching a physician or a group of physicians in the midst of cancer treatment or severe cardiac things or long-term care. That's a big deal, and that's very complicated. And to add the double whammy of these premium increases would, I think, be cruel to somebody in that situation. Is there a possibility?
Amy.
Yeah, hold on just a second, Dawn.
Go ahead.
Is there a possibility of baby stepping this, for lack of a better term, and allowing people time to transition before we hit them with the big change? Or is it January 1, 21?
Could you build in continuity of care for somebody
Exactly.
in treatment?
That's what that's the big words for it. Yeah.
If we were to start this on 1/1/21, I think that would be difficult, but we could certainly start to make an announcement a year or so out before it starts. So if we
Well,
did it
we're
for
only
22,
7
we could
months
do that.
away from that. We don't have a year.
But what I'm saying is if we choose not to do it for 2021 and say you want to do it for 2022, we could start to communicate with employees now to say that we will be offering a network come January 1st, 2022 through Parish and through Steward that we would want them to consider. And we can put all of that out there and then make it effective then if that's what you wish.
Yeah, but the problem with that is we delay, because what is the
money.
savings of the alternate network? And how much migration was assumed in the savings?
Yes, great question. Yeah, there are a few points that I want to make sure everyone understands on scenario 2. I know we've had a lot of good conversation about it, but I think there's some key points to point out here. First of all, if you're comparing scenario 2 to scenario 1, the plan designs are the same. So if you want to keep that in mind, that's where the $3.5 million is coming from, is that the plan design is the same in both scenarios. But the reason, as I think you all have seen so far, the reason we're getting to total estimated savings being the 9.3 million versus just 3.5 is because you are getting additional savings from the alternate network of 1.8 million. And to answer your question, the assumption here, and I apologize, I know it's hard to read, it's in small font, but our assumption here is that 50% migration will happen into the alternate network plan. Now, I know you have 80% going to Health First now. We do feel like the alternate network contributions, maintaining where they are today, will provide additional incentive for employees to move to that plan. In addition to people that aren't utilizing Health First or not needing those hospitalizations and those types of care. So for your other employees that aren't necessarily utilizing that particular side of the benefits would have the opportunity to keep their contributions the same and move to the alternate network with minimal disruption for those individuals.
ABK, what would, and again, I don't mean to put you on the spot because I know you've got to model it, but say we went to something more palatable, like a 25% change to the premiums, what kind of migration? Obviously, will it drop down to a third?
Right, and I actually do have a spreadsheet we can look at in a moment to test some of that, but I can tell you that our reasoning behind the way we set this up, now, I know either way it is a big number. 47% is a huge number. Completely understand that from your all's perspective. But I think focusing on the dollars and the dollar increases, because employees will be looking at what's the dollar difference in my paycheck, not necessarily what's the percentage increase. And not to say that $50 isn't a month, that's noticeable for a lot of your employees, I'm sure. But and the reason we did $50 differential is because based on our analysis and what we've seen historically, in order to encourage migration, you need enough of a difference, of a gap between those two contributions to really drive the migration. And so we did provide some scenarios. Now, this is all under the $50 differential on the contribution side, but if 25% migration instead of 50% migration, that total 9.3 would actually increase to 10.4. And the reason is because you have those additional contributions essentially coming in from more people staying in the PPO plan. But if you have more people migrate 75% than expected, the savings actually decreases from 9.3 to 8.2. This is in the footnotes, so I don't feel like you have to write it all down, but it is under the notes section. So there certainly is sensitivity around the number of people that migrate, what's the differential in that contribution piece. That's absolutely 100% of the driver of that $4 million change in employee contributions is driven by that $50 increase, or the 46.9% increase across the board for those that buy up to PPO, assuming 50% migrate to the alternate network.
Yeah.
Ms. Butterfield's asked to be recognized. Can we give her a moment, please? Go ahead, Dawn.
Yeah, I wanted to just to address a couple things. One, I can understand Anthony's concern about, everybody's used to going to Health First, but, as a huge plan in Brevard, what I think you'll see over time, and we've never done this for leverage, right, is say to these hospital systems, look, we're willing to walk. So, you either kind of, come down to a reasonable amount or you don't. So, yes, can it be painful the first year? And I think instead of, that's a large percent, but I think also on the regular side of the preferred or whatever the plan that we want them to be on, I think that part needs to go down. It needs to be an incentive for the employee to do that because it's going to take a lot of education. It's going to be a lot of saying, hey, you're going down. You have the opportunity to pay less in premiums. Are you going to be able to pick the hospital that's right around the corner from where you live? No. Might you have to change doctors? Yes. But, how many people use healthcare all the time at a hospital? Not a lot. So it's not like it's an everyday thing for everybody. That was my only comment.
Let me say something, too, because I think this is important. What Dawn said is absolutely 100% correct. Health First will not reduce their costs unless they see more people leave their hospital system. And I don't know how many were here when Susan Stanley was sitting in this chair, but many on this committee might remember when Health First said, if you don't give us a pay increase, we're off your plan. They did that 3 years ago, and increases came as well. If they don't believe we're willing to walk, or at least some of our employees are willing to go, then we're going to only have increases that continue on and on and on. And I think what Don said is absolutely correct. I really think we need to diversify our population.
Can we go and
Mark, I'm having some
Anthony.
trouble with what you're saying because I get the concept, but I once again, it's great that the board wants to be so brave with the employees' money and the employees, but the board had the opportunity to engage in a lawsuit against Health First and chose not to. So let's stop with that, okay? Because they had an opportunity to take action and they chose not to.
Well, I would like to look at this, and I agree the 46%, and I understand what you're saying of that drives migration. Nothing more than dollars will drive migration. But I look at this thing kind of objectively and say, we're trying to fill a 10.5 and we're taking 9.3 of it really from the membership because it's all coming from either driving them to a narrower network with the direct contracts and increasing their contributions. So I would like to temper this maybe a little bit to say, maybe don't take as much from the premium delta and maybe let's take the alternate plan design and make that a little bit more attractive. Maybe lower the copays, sweeten that plan a little bit. We're going to take some money off the table. We're going to take some savings off of the table. But I think that'd be more appropriate that those that are in that plan are going to have something that's maybe more in line with their current copay structure deductibles.
I agree, and I think Anthony mentioned this a few minutes ago too. When we first started talking about an alternative network or something, it was kind of a zero premium plan we had put out there. Well, that doesn't seem feasible, but I do think there needs to be a lot of sweetening of that deal. Out-of-pocket maxes need to be lowered. All of those kind of things to make that more enticing.
If we went,
even if the premium has to stay the same.
I would say look at something like a 30% on the OAP current plan with the plan design, and then let's take some more off of here and realize we're not going to net as much savings. We're not going to get as much migration, so we're not going to get as much network savings as we had hoped. We're not going to get as much premium savings as we hope.
And I
But
think
it's
a
moving
lot
the
of,
needle.
I know what you say that dollars have a lot to do with migration, and I 100% agree with that, but I think education has a lot to do with that too.
And enrollment strategy, are we going to go passive versus active enrollment? I would assume we'd want to go active because we'd want them to make a choice.
We need to make people, especially the 80% of people in the south end of the county that use Health First only, we've got to make them realize that they have accessibility to care and that they need to start being proactive in making those changes now for that to happen,
And
if
this
this
Dawn.
is something we go.
Yeah.
Go ahead, Dawn.
This is Don, and you know, I worked at Mass General, and or I called on them in Boston Medical Mecca. I'm a medical snob, seriously, and so to me, a local community is like I've never lived in a place like this, but the affiliation with Parish to Mayo and to Nemours is a huge sell to me. That just makes everything, because Health First, the best that they're doing is Orlando Health and Advent Health, and that's just still a local thing. I'm not even sure if they're, you know, with Moffitt, but I would take my chances at Mayo any day of the week if something, you know, I needed some kind of specialist.
Stewart also has access to the Cleveland Clinic, which a lot of people like as well.
And that's the kind of stuff we need
There
to
you
make
go.
people know, because a lot of people, when you say Stewart Hospital, they're like, I don't know where Stewart Hospital is. They don't understand it's a network of hospitals. They don't know that we're saying Rockledge Regional and Melbourne Regional. We need to educate so that people know what we're talking about.
Clearly, an education plan is required.
It's going to be huge. And we still haven't done it. I think between Jeff and myself and you, Anthony, as former classroom educators, the three of us could sit around a table and put together something that could be pushed out in video or PowerPoint or something that is a mandate watch when we're having to watch our bloodborne pathogen things and all that kind of stuff, that is a mandate watch that could thoroughly educate people.
So I have a question. The scenario 2 changes the premiums on the employee, whereas scenario 1 does not, correct? 0% on scenario 1.
So
Why don't we have an option here that includes the alternate network, perhaps just like Mike said a minute ago, where it's essentially a reduced cost to the employee to go there, so we're trying to use a carrot as opposed to a stick, but while still maintaining, not changing the employee contribution. Where's that scenario?
That's what we're...
All of those, if you want to look and see what that does to the overall plan, I believe ABK has that built into scenarios.
Yeah, I think let's get to that point. Yeah.
Might I suggest this? If you would wish to vote on whether we consider the alternate network or not, and if that's a yes, ABK can set up a computer and run different scenarios to show what that would do to the plan.
As
If
long
you
as it's a
don't like the
benefit.
way this is set up, she can do that now.
I think I would like to get to that point. Does anybody have a... I'm sorry,
make a
Jeff, go
motion
ahead.
that we consider it, as long as it's at a reduced cost to the employee.
And that's why she would bring up her generator thing so that we can play with those numbers for that very reason.
Mark, can I make a couple comments about the alternate network first? Sure. Is that okay? Yeah, so it's my understanding the alternate network will also have an out-of-network benefit. Is that correct?
Yes.
So if you wanted to go to Health First Health Plan, you still can go. You just pay more to go out-of-network. And to make it easier during transition, for those people who do want to join that network, the alternate network during open enrollment, if they already have a scheduled procedure at a Health First facility after 1/1, we can grandfather them in.
What
This
procedure would it
network,
take to do that if you already had?
We would just load that authorization that's in our system for Health First after 1/1 to those people that are in that network. So they get the in-network benefit level at Health First during that transition period.
Okay, so just to clarify, if I, as a family who doesn't go to the doctor very often, decided, you know what, I want to keep my premiums the same, I'll take the alternate network, but I do like Holmes Hospital, so which is Health First. So if one of my family members has to go to the hospital, I'm going to go to Holmes. I'm going to pay the out-of-network cost, which is a higher cost to me.
Correct.
But I can still choose that.
Correct. But if in December you have a procedure at Holmes that's scheduled for, let's say, February, we can then load that authorization in our system for you in that alternate network, so you're paid at the in-network level during that 3 or 4 month transition period.
So there can be a grace period, basically.
Yes, we can do that to make it easier for you.
But Brian, that out-of-network, just to your point, is going to follow usual and customary, so there's potential for balance billing. I want to make sure we understand that, that it's not, you're just not subject to this. all out of network
But
works
it
the
will
same.
be Cigna's reimbursement. It'll be
Yeah,
at
they're
our
going to
current
be in
reimbursement
their
level that we pay them
reimbursement, and
today.
if there's any balance billing, that exposes the member to some risk.
Yeah, typically you reimburse at a lower level, but we're going to reimburse them at our contracted rate that we have today. So it's not, they're
Going
going
to
to.
be as drastic?
Won't be
Right.
as drastic, right?
And that's one of the reasons why that and the potential raise in deductibles that we're going to be looking at on just a regular plan is one of the reasons why I asked, and now it's not that we can talk about it later. I asked Mark to bring some more information about AFLAC because I think if we're going to do that, we're going to raise our deductibles a significant amount and raise our out-of-pocket maximums. We need to know what our options are, employees who are in those bigger bubbles on the bubble chart, what options they have. Because it doesn't mean that we expose the employer to the complete cost. If they have a plan like AFLAC, they actually can have a significant amount of that taken care of. And because that's scary for the people who always meet their deductible or who are expecting to, they need to have something to fall back on. And so I am not as super familiar with the AFLAC plan, so I'd ask Mark to give us some information about that.
Yeah, I just brought the group hospital indemnity plan, and for the employee only, that's $14.20 per pay period. And basically what that'll do is if there's a hospital admission, it'll pay them $100. If there's a confinement, hospital admission is $500. Hospital confinement is additional $100, and I believe that's per day. Intensive care units, $100 a day. Intermediate step-down units, $50. There's a whole schedule of what they would pay. If you had surgery, it'll pay $250 of that cost. For inpatient, outpatient, $125. There's a whole listing of fees that come with that hospital indemnity program.
Is that the bottom of the line, or that's just the standard?
That is the standard. I mean, I can
Okay.
pass this around so you can see what those are, and maybe I'll do that.
Okay.
So you can pass that around to show that. There is also a critical illness, and that's going to be depending on your age as far as the rates are concerned. But and if you're a tobacco smoker or a non-tobacco user, but that does pay a flat rate depending on what you choose. So you can, I believe on critical illness, you can choose a 5,000 or a 10,000 rate, and those rates are built into this schedule. So I will pass that around. Here is there's a group accident rate, and maybe I need to pass the booklets around as well, so you can see each one of the brochures. If you want to look through those, you can. Those brochures tell you exactly what would be reimbursed based on the monthly cost for those voluntary programs. For example, the accident rate, and it's in the book what it recovers, but for the employee, it's $9.15 per pay period, but it has a whole outline of things that they will cover if somebody is injured due to an accident. And so those plans, we can pass those around for anybody to look at.
And then you use hand sanitizer.
I'd like to just mention all of that information we're passing around is posted on Easy Benefits. Just
Yeah,
click the
it's on the
AFLAC
website.
tab and it's all right there.
Thank you.
Go ahead, Jeff.
If I may. And I know I asked this question last week, and I have, or something similar, and I still want to make sure I understand, as far as when we move forward, this $12 million that we think that we're short, does that include our current balance, or would that keep us at the same current fund balance that we have?
By December 31st, 2021, so it's a year and a half from now, we're expecting that our trust fund, this is what Aon's projections are, is our trust fund will have a negative $12.5 million trust fund balance.
So even if we do 12.5, we're talking about having zero in the trust
That is
fund?
correct.
Okay. And then the second point I just want to reiterate, the 3.5, I know we kind of came up with that at the end of the last meeting, but I still want to remind everybody that this right here is a ratcheting up process that goes towards the employees. And so we need to be cautious. We're thinking, okay, we're doing a third of it out of the plan change. I think we need to do less. If it's 12 is the accurate number, perhaps premiums are going to have to be more, a bigger increase, because we're not going to try to get to zero, obviously. I think we need to be above zero in order to be successful.
You can certainly look at any rates. That's why ABK is here to do that kind of figuring today. I just want to remind you that getting to a zero by December 31st, 2021 would be difficult without plan design changes as well as premium increases. So, but we don't know what those premium, or if there would be a premium increase or how much that would be at this point.
Yeah, but if the goal is ultimately, if we're talking about trying to get to the 12, and we're doing a third of it out of plan benefit changes, which is negatively impacting the employees, we've already done our portion of it. I think, so are you going to, so the rest of the assumption, like in scenario 2, should be assuming that the board's going to increase whatever's necessary for premiums to keep the fund balance level.
Okay, but let me just
So,
remind you that
I'm
there's
sorry.
only one group of people, one body, that if, when this is not at the minimum for the state to keep our self-funded, there's only one place that money can come from, and that's from the board. So we talk about third, and someone's already said, I think Mike even said, okay, well, 2/3 is on the backs of the employee, but that's not necessarily true, because whether it's $10 million, $12 million, $25 million, if we're short when it comes time, not this summer, looks like we'll probably be okay, but next summer or the following summer when we're due to return our reports, that money can only come from the board, from the district, and which, you know, I just want us to keep in mind, because it's all nice in theory to say, okay, well, this is on the backs of the employees, but it's not. It's our plan. And it is to the benefit
The employees
of
pay.
all of us to have this self-funded plan and to keep it healthy. And that's what the point of this committee is to keep this plan healthy. But I just want to remind you that it's not quite as cut and dry as that when you talk about where the money's going to come from.
Well, the point being is that right now, it's about 2/3 of the premium are coming from the employer, correct?
2/3 of the premium?
Is that correct?
Yes, I would say that's
The board
correct.
contributions, about 2/3. So right now, we're
Actually,
talking.
it's more than that. It's like 75%.
75, okay. I don't know what the exact numbers, but that's a rule of thumb.
So it's 3/4, I would say.
3/4, okay. So if we're going to be doing increases, I just think that the end goal should be equitable across all boards, from the employee and the board. If the board can't afford it, then what makes you think that the employees can afford it? So I think that we need to use that. That's the big picture. Then what we're going to do on the employees, we need to break it up between premium and plan changes. So I think even 3.5 is too much. That's the end. I think maybe we need to reduce that a little bit.
Realize that you're swimming upstream against a 6% trend. So, you got a $50 million plan, you got a 6% trend, you got $3 million going to your claim spend every single year that you have to. So I think saying that it's not enough, I'm not sure captures the complete trend picture into the factor. I mean, we're burning $2 million a quarter, that's $8 million a year, plus we've got 18 months of trend that we have to factor in for, so that, you've got at least 11 million, and then guess what? Lather, rinse, repeat, we're back at it for 2021, 2022, 2023. And that's the problem we found ourselves in here, is we haven't done anything for 6 years. And I think your point is spot on. You can't go back and collect more from the employees. So if there is a shortfall, if claims go above expected, and again, with a plan with 11,000 members, you're at a pretty good statistical probability. Within probably, ABK, 3 or 4%, that you're probably within a 98% probability of that?
Right, and I think to add to your trend comment, now this hasn't been peer reviewed, so I have to caveat that, because all AN numbers we are required to peer review, but I did get a response back on the pharmacy alone trend, and it has had a lot of volatility. In fact, more than what we saw the medical pharmacy blend. So we've had some years, and this is going back to 2010, some years as high as 17% over 1 year, and the lowest years you actually had a 28% reduction from the prior year. So there's been significant volatility in the pharmacy trend over the years.
So I go back to Mark started and said, does that work for everybody? And I said no, because look, this is the same scenario that we happen every time. We pretend like it's going to be a fair process, but somehow it always comes back to, now we're looking at putting, what is it, 9.5 million, 9.3 on the employees, and alleviates the board from doing anything.
I agree with you on that we need to probably slope down the plan design changes to the alternate network, and we probably need to slope down at some level the increases to the current plan, to the OAP plan. I think we take a little bit of money off the table. That would be my position, is let's maybe go to a 30% or a 25% increase on the OAP plan, and let's maybe make that alternate plan design a little bit more attractive, closer to what they currently have.
Remember, this is just a hypothetical. It's not the final.
Mark, when you give us those hypotheticals and we have a bunch of non-voting members on this committee, and then we always seem to get pushed to what works best for the board. And, if you don't want to talk about bargaining, fine, I get it, but you're going to waste a lot of time because we are going to go to the bargaining table.
I mean, Anthony, I would ask you, and all folks that are on the plan or represent, membership, is 25%, is that something that would be acceptable from a premium increase? Recognizing if you acknowledge that there is a shortfall that's going to happen.
I completely understand that raising premiums may have to happen. But it's hard to say we're going to raise premiums and offer you less, and we're going to take away 80% of your doctors. So that.
Yeah, and I agree with you. Getting hit with both a premium increase and a plan design modification to make it less comprehensive is not ideal. But part of that's been driven by the fact that we haven't done anything for 6 years.
But wait a second, because you
Okay, Mike, this is Dawn. I'd like to kind of, I'm sorry to Katie to break in, but you keep saying that, and I want to remind everybody, we've done a lot in 6 years. Okay, they've come to us every single year with this Mayday scenario, and we have to go up on premiums, and we have to make the benefits more horrible, whatever, and we've said no. We're going to do this, we're going to do that, and we don't think so, and we've fought back. We did an RFP, even though it wasn't brilliant. We got more in rebates because of that. We got an administrative holiday because of that. So we have made some changes. I don't think, until we exhaust all options to look at the money in the middle, okay, I am not willing myself to put any more money or to recommend Tina, my board member, or even the employees that I'm texting asking how they would feel about some things. I don't think that we should put any more money into all of that because we have not fully exhausted all of that. We changed one bad broker to another broker that's doing the same exact thing. So I don't think we fully have looked at everything, and I don't think this is Mayday. I think that there's a lot of good things that are happening in the marketplace, and that's where I'm going to end my rant, Amy. I'll end my rant there.
If I can respond, I think we have done a very admirable job in controlling the fixed side of the costs here. I think we have done a phenomenal job renegotiating the rebates, renegotiating the contracts, getting some premium holidays on that. The reality is that's only 10% of the spend or 8% of the spend. Where the spend is on the claims, and we haven't done a whole lot on the claim side to control that. So, I mean, I just, I think the time for vetting, the good idea fairies is over with, and we need to go with things that are going to produce results that we know are going to happen.
Can I move that we go ahead and let ABK walk us through some number changes and see what it is we can do to make a practical recommendation without the narrow network at this point?
Are you asking to reduce the premiums to 25% rather than 46.9?
Right, so I think I heard you say, did you say PPO only, or did you say dual
Well, the alternate network seems to be a point of contention right now, so let's just work with what we have currently going on, I guess scenario one.
This is scenario 2, actually, is that, I just want to be clear what we're talking about. Scenario 2 is the one that offers the alternate network.
We take an alternate off the table, or?
Well, I made a motion, I know it wasn't seconded earlier, that we consider it as long as there's a reduced cost to the employer.
Okay.
So we use the sweetener as opposed, which I think is what I understood
Yeah,
Mike
and
was
I'd like
saying.
to, I'd like to kind of split that of either keep the cost where it is and make the benefit design more attractive, maybe lower those copays, deductibles out of pockets, or take 3% off of it, make it $100 instead of $106. I mean, I don't think there's a whole lot of premium that you can take off the table, but to me, make the plan design more attractive, because that's going to help. You can either do it with premium dollars to make it migration happen, or you can do it with plan design. Both of those things are going to have have an impact.
Okay, so let's, scenario 2.
Well, do we want to vote on whether we do the alternate network based on what was proposed or not? I think we need, I see somebody shaking their head.
Okay.
Do we have a motion?
Do we have a motion to include the alternate network? So,
I made a motion as long as it is not at an increased cost.
and we will play with the numbers here in our, and do you second
I
that,
will
Sharon?
second that
Okay.
motion.
Let's do a voice.
Let's do a voice vote. Ms. Butterfield, are you okay with that, or no?
Yes, yes.
Mr. Bailey is here. Is there anybody else that's a voting member on the phone call?
Can you hear me?
Sheila, are you there?
Yes.
Can you hear me at all?
Yes, we can hear you.
Okay. I couldn't tell.
Do you agree or no?
Yes, I would agree for including an alternate network.
Okay, and let's just go around the table then. Anthony?
What is the question?
We are voting to include an alternate network in the discussion and allow us to work with the numbers to see if that is feasible.
Sure, aye.
Aye. Okay, Jeff, you moved. Go ahead. Yes, you've already moved. Go ahead. Yes?
Yes.
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 And a yes from me, so let's go ahead
That's
and.
unanimous, yes.
Unanimous, yes. Let's include it and play with those numbers, please.
Okay. So playing with the contributions will be separate with playing with the plan design. So what I've pulled up here first is the contributions. Would you prefer to start with contributions or plan design?
Contributions, let's just
Okay.
start at the top of the page, please.
Okay, great. So what you're seeing here is laid out exactly as you see it in your slides for scenario 2. So if you want to let me know how you, for example, for the alternate plan, where would you like me to start off at?
Can we start with reducing the employee increase to 25% for the OAP?
Right.
Mhm.
Yes. Okay, so if we do that, you'll see, so 25% increase, reduction goes down to 2667 for the single tier. Let me add a quick calculation here for this versus this. So right now, we have a 2667 differential, which in order to encourage migration, we do believe that needs to be closer to 50. But based on just that one change, that would, the buy-up then for those employees would be from 106 up to 133, difference being 2667 per month from what they pay today. And the total employee increase would drop from what we saw originally on scenario 2 from 4 million down to 2.14 million. Now, I do, I would think as a second point, you would want to consider a reduction to the 106.67 to create that $50 differential. That is going to lower employee contribution impact, which doesn't help your bottom line as far as total target for what total savings are. And I know that the goal today is really around the 3.5 million. I just want to point that out. If we do create a $50 distribution at a lower OAP plan contribution, that will lower.
Can we leave that where it is for a moment until we looked at down with the actual plan design part of it?
Sure.
And then get a whole picture before we decide to go back up and play with
Yes.
other premiums?
Okay.
Does that
All
make
right.
sense?
Okay.
I can't.
To zoom in?
Yes, as long as you're okay that we can't see everything on this at the same point. Yes.
Yes, zooming in would be beneficial.
Yes, just a moment. I apologize. I know this is small. Let me just get this adjusted to.
Can you repeat those numbers again, please?
So what we were just looking at on the contribution side, we reduced the increase to the OAP plan where it was 47%. Now it is down to a 25% increase to the OAP buy-up. So the contribution for the single tier for OAP is now 133.34. And the other tiers drop accordingly because all tiers were applied at the 25% increase instead of the 47, 49, 47, I think where we were. So therefore, the total increase from employees from the contribution side is now 2.1 versus the original 4 million you see in the PowerPoint. Okay, so then to go on to plan designs. Okay, so scenario 2, this is essentially how scenario 2 in the plan is set up. So based on, okay, sorry, you asked me to zoom and I haven't zoomed. But you also, for this portion at least, you do have your PowerPoint to rely on. So based on what you see for scenario 2, what aspects of the alternate network would you like me to improve in order to increase the value of that plan?
You go to 1,000 deductible?
I'd go down to generic medications or $10 or less.
Well, let's start at the top and work our way down. Let's,
Okay.
we've had a
Go ahead.
recommendation for $1,000 deductible in network.
Sorry, I'm trying to find hidden cells here. One sec. Oh, there are no hidden cells. Because we had mapped the designs to mirror each other, I was working under the assumption that we actually had broken out the two plans to be able to isolate them separately. But I do not believe
You don't have that available?
that we have that ability right now. However, trying to think of how we can play around with this differently. Jackson, if you are listening, let me know if I'm overlooking where we can alter the narrow network without altering the PPO.
If you did it in
There currently isn't a way in that model.
I'm sorry, Jackson?
There's not a way in that model. That model was built so that both plans are the same.
Okay.
I can send you an updated model probably within the next 30 to 45 minutes where you can do that if you want me to.
Our meeting will be over in an hour.
Right, yeah, so unfortunately, we don't have time for that.
What about, ABK, what about doing it in Plan Design 1 and then looking at the delta? I know we're dealing OAP network.
Exactly, so we won't
that'll
see
give us a
the impacts to
frequency.
narrow network savings and that sort of thing, but we could test it in PPO. Okay, so we're starting with scenario, well, and we can still start with scenario 2. I mean, that's dual, so let me just do that, and just know that when you see it on the PPO, it's not, well, scenario 1 is actually, we can turn off the narrow network, we can't turn off the PPO network.
You just didn't play, because we're looking for a delta, we're looking for a
Right,
frequency change.
right. So let me do that as,
Because I don't think we're going to get accurate on what the alternate network savings is, but we'll get it on the delta between the plan design change.
okay, so right now, I've essentially replaced scenario 1 with scenario 2 in the model, and we're talking about changing the deductible to 1,000, correct?
Yep.
Okay, so 1,000, which means that the family deductible, I'm assuming we want that to continue to be 2 times, so that would be 2,000. This would be 1,000.
How many?
And out-of-pocket maximum, any changes to out-of-pocket maximum?
I would bump that down by $1,000, maybe to $4,500.
Which is, that's where you are today.
Chair, if I may. I just want to give clarification.
go
I think
ahead.
there might even been a question of regarding the motion, so I just want to clarify. When I talk about it being less for the employee, we're looking to be, nothing should be above what we are currently paying as far as the plan design.
Right, for the alternative.
So I don't know if
Right.
that was clearly
Yes, yeah.
communicated.
And now we're playing with the actual numbers inside of the plan to see if we can sweeten the deal to make it
Yeah, I
a little more
understand, but when she
enticing.
asked, we certainly, everything needs to at least go back to the previous plan.
Correct.
So you want the plan to, your thought was the plan design would be the same as current?
Yeah, it'd be better, the same or better, yeah.
Well, that would be an easy
Better,
reset,
better,
is to
it-
set it back to what we have now.
If it's not better, then, as Mike suggested, then there should be some change in the premium, one or the other.
Right.
So make are you recommending keeping the alternative network
To current?
current, like we are current now, or better?
Correct. The plan.
The whole
Yeah,
plan.
so if there's any question about, yeah, almost everything I think needs to change.
From premiums all the way down, just reset the whole thing to what we are now.
To the current, yeah.
Mhm.
It just instead of
And
asking.
then any increases that would be made in the PPO.
Correct.
Or the OAP, I'm sorry, the OAP.
Well, the PPO was suggested by the 20, look at 25%. We didn't vote on that, but
But-
that's what Mike was asking for.
Okay.
So I got a little confused of where we're going back to, but if we go back to the contributions, do you want to do that, or do you want to go back to plan design?
Well, I think the recommendation is for the entire alternate network plan to mirror what our current 2020 OAP is now.
Okay.
So what I'm hearing, just to make sure I understand, what you're talking about is the same premium that we're currently paying with the same plan design.
No, because that's
When
not
did
a
they
better
need to be
plan. It's got to be one or the other, or both.
Okay.
Lower premiums and lower co-pays, or one.
It's going to be lower than what proposed is for the Cigna plan.
Yeah.
So if we keep it at what our current plan is, and we're getting those discounts.
And then the other ones, everything's going to have to go up.
Yeah, I don't think you can make it lower premium and better plan. I think that's
Well,
not
I'd like to
operating
look
in-
at just the lower premium then. Lower premium than current.
So this example that's on the board would be essentially equivalent to what your premium income is today. Because I added, so we've changed the buy-up to a 25% increase, but for the alternate network plan, we're decreasing it by 25%. So if you look to column J, and I can make this larger as well if we need to, there's no increase year over year because they're offsetting each other. So you have a $26 increase to this plan, but a $26 decrease to this plan. Therefore, there's no impact to employee contributions in this scenario. So if you did this, if you kept the plan designs as they are in the PowerPoint scenario too, then you would still have $3.5 million in plan design savings. You would still have alternate network savings of 1.8 million, assuming 50% migration, which I think is doable with the $50 differential. Actually, in this case, it's a $53 differential between the low and the high plan. You just wouldn't have that employee contribution change of 4 million in this scenario.
So what you're estimating the savings still at 1.8 for the alternate plan design because the migration is going to stay there.
Yes.
We're going to save 3.5. Are we still saving 3.5?
Yes, because the plan designs.
Well, no, we aren't because we've modified the plan design back to. We've modified. If I'm understanding this correctly, we're taking the current plan design and we are putting it in the alternate network. Or we're keeping it, everything's going up in plan design and we're just messing with the premiums. I mean, which one are we solving for here?
That's the way I understand it, is that the recommendation is to leave the alternate network at the current 2020 rates, everything, the whole picture, right?
Okay, we're keeping the
Okay.
rates the same, we're going up on the OAP plan, 25%.
And that would be the sweetener, is that to go into that alternate network, you would not have an increase in your out-of-pocket max and your
So-
deductibles and everything like that.
Okay.
So
That'd
we
at least
would be
a sweetener, Or if we
eliminating.
did the $100 in the premium, I don't know how much that's going to affect it, but at least we can say the premium's going to go down, but just, look, the employees ultimately, we're going to have to eat something. I know, ultimately, there's going to be there's going to be some type of change, but trying to, at least if we're going to get people on the alternative network, let's do it with sweetener, even if it's not even if it's not a great sweetener. I just don't understand why we'd have any type of scenario with an alternative network where it's going up along with the OAP.
And ABK's got the scenario up there right now where there's a
You don't get
25%
3.5
increase to stay with the AOP, but also a 25% decrease in premium to go to the alternate network, giving us that 50% spread
But you're going to lose.
that will drive.
But,
But you'll drive
if
those-
if every single belly button went into
The alternate.
the new plan design with the increase, you save 3.5 million. If you have 50% migration into the alternate network
Mhm.
at the current plan design, you've taken some of that savings off the table, right? Because some of that is increased out-of-pocket, increased deductibles and copays. So we're not getting 3.5 million anymore. So
Right,
I,
so-
I
How
would
are we getting-
say.
That's what I want to know. How much?
That's, it, so essentially, because they have the same plan designs and now both are offering out-of-network benefits, you essentially cut that savings in half. So
Yeah.
it'd be half of 3.5
So
million.
you basically, you only get 1.75. I would tell you, in this current world, you know, at least the one I woke up in this morning, if you go into a renewal and your premiums don't change and your plan design don't change, that's a win. That's a good thing.
Meaning going up.
Yeah, so where we flipped the, you know, when we went 25% up on the OAP, I would recommend, and I hope you don't look at it as I'm trying to take the board's side on this, but I think we got to look at reality here. If you go into a year and don't have a premium increase, and technically your plan design doesn't change, but the only thing that really changes is the amount of access points that you have, but you still have a suitable thing. Where we are, I think that's a good thing, honestly, and I'm not trying to sell it.
Mike, are you going to tell them that they can keep their doctors under the new alternative plan? Or is that where this is going?
No, they can pay more and get back to their
No, we're going
doctors.
to take their doctors away, at least some of them.
I
So,
mean,
I hear
because
ya.
that's the part that we keep forgetting is that 80% of our doctor visits are not going to be to our doctors anymore.
But
But
not
this-
everybody's going to go to this. And the other thing that concerns
not
me is,
accurate.
if
That's
we
not
do
an
all
accurate
this and
statement.
we cut the savings, then we're going to have to make the OAP plan pretty ugly to get most of that $3.5 million of savings that we're trying to find today. It's going to have to come out of that and make the plan that people are going to want to pay extra for really nasty.
I just think
So
this gives
Chris,
people
can you
choice.
explain? I'm
yeah, I
all
wanna hear
ears.
Chris's
It was
point.
two different discussions.
could you
The
speak into the
80% into the
plan
mic, Mike.
that we were talking about was that other plan.
Speaking of the mic, yeah.
Was that other plan thing that we had here for the program changes. That was what that was about. That's not what we're talking about with the narrow network. We're not saying that. I believe the disruption was very, very small.
No, the disruption on the narrow network was 80% of our people are using Health First. Am I not correct?
That was the CDC.
No, but no, because the thing is that many of those doctors are also in our network as well. They're in multiple networks.
Right.
So as a result, you're not going to see that kind of disruption.
So what I don't understand is that we got a list emailed to us because it was requested by a committee member last meeting. And what I hear today is that that list is not fully encompassing all the providers.
So even though 80% of
where
them,
are all the providers? Like, why don't we
Yeah.
have that information to see
I think
that
those are the
actual
providers that are actually employed by that hospital system. And so what Chris did is added all the other doctors that aren't paid by the hospital, but they have, right, Chris, that
That's
are
right.
affiliated with
But
that.
they're
They're
still
affiliated with
relevant.
multiple networks.
Correct.
so they can
but we need to
still
see it, though. We
technically
need to
see the
know.
same physician because they are also not only in Health First, but also with Parish or Steward.
Correct.
Steward.
In the
right.
past.
I didn't
Go
find
ahead,
any
go
of my
ahead.
In
doctors. on
prior
there.
years, and I'm going back the last few years, but I'm also going back years ago, 15 years, when this kind of thing came up, we would get a list that would have the doctors, it would have the columns across the top, it would have X's that they are in this network, this network, this network, so that then we could see
We need
that our employees are going to these doctors, and these doctors are still going to be in
They're still
this
good.
network, this network, this
I
network.
think that would be valuable information to have. Is that something that we can get, like, soon? And not so much the doctors that we'll be able to retain, but it's primarily the doctors that we will not be able to use anymore because they are not in multiple networks. And then that would have to be the focus of the education piece if this becomes an option. Go ahead, Anthony.
So the list that we have has, for Parish, 52 doctors, and for Steward, 345, and I think many of those are not even in Brevard County. So that's what I'm looking at, Chris, and I'm looking at like my doctors, family doctors that are major providers in Brevard County, and they are not on these lists.
Yeah, and what we said earlier in this discussion today, and what I said earlier today, was that number only reflected from us, only reflected the doctors we actually employ. there are another 450 doctors that are actually in the parish health network in Brevard County.
And so do you think Stewart reported it that way as well? I mean, would you have any idea? I mean, is there a chance that would grow too?
Yes,
Okay.
I think the number for Stewart is also low, but I also know too that, about a year ago, Stewart was pretty comparable to where we are. But we've been adding doctors and other providers at the rate of 5 to 10 per month.
Thank you.
Stewart
I think it's true about Stewart too, by the way, just my opinion.
The Steward list does list their facility name, and so some of those, if you look, are in, looks like Woodstock Health Systems, but some of them are their own clinics, like Surfside Urgent Healthcare in Indialantic, and some of those. So that's on that spreadsheet that we got. Do you see that, Anthony?
Yeah.
So I think the Steward list does include some besides just the hospital doctors.
I mean, what's going to actually do?
Okay, so I mean, I would like, let's move forward with the discussion, but, what I'm afraid of, and I've seen it happen time and time in this committee, I keep saying it, just because we move forward and let's say that these lists don't grow and these are narrow network, a narrow network, I just see in this committee that somehow because we say, let's discuss it further, then becomes we're doing this. So what I'm saying is I want to keep talking about it, but I'm not convinced based on this list that this is anything to give to our employees.
Is this accessible now? I mean, I just don't understand why it's not at this meeting after. I just don't understand why we don't have it.
The list that I provided before is what I got from Brian on doctors that are in each one of their networks. I did just receive Chris's information yesterday. I'm waiting for that for Stewart. I'm hoping, Brian, when can we get a list of all the doctors that have access to Stewart Hospital?
I've asked them for this.
Yeah.
If-
If we could have a spreadsheet provided that had the overlap, and most importantly, in my perspective, and I'm very visual, is I would like the outliers, the ones that will no longer be accessible under this alternative network.
Not accessible, they are, because you can go out the network.
No, I mean that they are not within the alternative network in-network plan.
That's still
That if
disruption.
you're going to pay out your nose if you go to this doctor. That's the ones I want to see a list of to see how much disruption's there with those doctors.
If this committee wants, I can try and set this room up again a week from today. I can hopefully get that list. Brian, how quickly can we get it?
Today's Thursday, it's not by tomorrow, by Monday.
Is Monday enough time for you to look at that list? My recommendation would be, let's run through these numbers. I can provide that list as soon as I get it to you. And then if you want, we can come back a week from today. Or if we can't meet in person, we can do a Zoom call or whatever it is after you've had a chance to look at the list, and then you can vote on whether this is something you would like to do or not.
Well, I like the idea of reconvening in a week, but I think we need to finish playing with the numbers and try to nail something down here before we leave here today. And we have about 45 minutes. Does anybody else have anything that ABK, any suggestions, recommendations, number shifts that you'd like her to do to show us some differential there?
So, and I'm just playing with the math here, but if we basically went up 25% on the OAP, we didn't raise premiums on the alternate, and kept the alternate plan design at current, it seems to me that saves about assuming a 50% migration, 5.6 million. Right? We're going to get 2.1 from the premium change. We're still going to get 1.8 because we're dealing with the same migration from the network savings. And we get 1.75-ish in premium increases on those that stay on the OAP. So that's about 5.6.
And that's above and beyond the 3.5 that was our target? Are we done here?
One caution I would.
I haven't seen,
I'm sorry? Who spoke?
I'm sorry, I haven't seen, this is Sheila. I haven't seen the numbers calculated for what Mike just stated. I'm not.
Sheila, could you get a little closer to your microphone, please?
I'm sorry.
There you go.
I'm sorry, thank you. I'm not seeing the numbers calculate that Mike was just discussing, where we take the up 25%, and then on the alternative network, we make that look like the current plan design.
Mm-hmm.
I haven't seen those numbers. I'm looking at a room. I have no chart in front of me, no nothing.
Can you see the screen that ABK is projecting right now?
No.
All right.
No.
Okay, I guess you have to be live streaming on YouTube to be able to see that, maybe.
I am live streaming.
And you can't see the screen? Okay.
There is a
Nope, it's showing the conference room, and it's kind of stalled.
Okay.
Yeah, I can walk through
So that's
them.
what I'm saying.
I mean,
It's very difficult for me to see what it is you guys are talking about and following, and I apologize.
And we can send out screenshots of
Yeah, ABK says she is more than willing to send out screenshots to help everybody see this.
It's up on YouTube now. There's a lag.
Oh, there's a lag. Can you see it now?
No, not yet.
But it doesn't show the plan design. It doesn't show. Did you do that? What they asked to put the plan?
you can't because they're not disassociated right now.
Yeah,
I'd like
but
Mike
for
to
the
walk
next
through
meeting,
them.
we can separate them.
Yeah. So, you know,
I'm going to have to depart in no less than about half an hour is my
All right.
max that I can stay. So show a screenshot or
I can walk through them verbally.
I agree. I'd like to be able to see it.
Let Mike talk you through it for now, at least. Go ahead, Mike.
So initially with the plan design changes, if we put everybody into the new plan design that was looked at, that's been proposed, that would save $3.5 million. We're talking about keeping the alternate network at the current, which is basically going to, if we have 50% migration, we're going to get 50% of that 3.5. So we've got, you know, the 1.75 million
Right.
there.
I understand that.
Okay.
I understand that.
Okay, so then-
I thought we were working on doing an alternative on scenario 2.
Correct. So that's what we're walking through. So basically, the proposal was to keep the alternate network plan design at the current plan design, which is going to take the savings from plan design changes down to 1.75. We're still assuming a 50% migration, which is going to save 1.8 million from the alternate network savings. We modified the premium adjustments from 46% down to 25%, and that reduced the impact there from 4 million of savings down to 2.1. So if you add all those up, you come up with about 5.6 million.
Okay.
What would it look like if we bumped that to 30%? Can we look at that?
Sure.
Thank you.
So you'd have a $32 differential between the two plans. And one comment that I haven't made yet on lowering the contributions on the alternate network plan is that you do run the risk of lowering the revenue into the plan to cover the cost of the plan. So essentially, if you were to do what you're discussing, your alternate network plan would be a richer plan than the PPO plan, but you're charging noticeably less. And so especially if you lower the contributions below where they are today, you run a risk in the migration. If you have a lot of migration into that, you're going to lower the revenue into the plan. So if this is a scenario you want to look at, I can certainly do that where we lower the plan, but you need to really look at that all encompassing of what does that mean to the
Yeah,
total
but that'll
revenue.
get offset by some of the additional network savings that'll be associated with it.
Yes.
So, you know, so it's not a dollar for dollar change. Yeah, there's a little bit of a wash to it. I mean, there's always a risk. I mean, the migration model is an assumption. That's all it is. I mean, you come up with what you think it's going to happen based upon the delta between the two.
So I just want to, okay, so in this scenario that involves enormous changes, premium increases, and, you know, we keep pointing out, you know, just the individual premium increase, but you could see what that is on a family plan. You know, it only gets us $2 more million than minor changes on plan scenario 1, and that's without any premium increases. So I just tend to think that scenario 2, an alternative network, hoping the migration is what it is, asking people to give up their doctors, that's a lot for just an additional
But
$2 million.
It's an option at $2 million, and remember, 50% of the population is going to have no impact to their premium and no impact to their out-of-pocket exposure, right? So that's better for that 50%. You know, Plan Design 1, where we push every belly button into the new plan design, you know, all of their out-of-pockets are going to be impacted.
Possibly their premium.
And potentially their premiums, you know, depending on how the negotiations go. I mean, I think it's an option. I mean, it really lets people choose. And we've talked about in this body of having choice, right? We've talked about having alternate options for those that, you know, are willing to be flexible with their providers, that they have an option that keeps their costs lower.
That's what I'm thinking, Anthony, is, like Mike mentioned a little while ago, we're going to have to just swallow the fact that stuff's going to get more expensive.
I know, but
And-
it's not a real choice if you're an employee on the family plan, right? So how much is that going to go up an employee on the family plan?
$730
But that's
on the
that's not a choice. It's you have to do it to survive. I mean, that's a lot of money coming out of your paycheck.
But if we
So you
keep
think we
the
should reorganize
alternative,
it?
if we
Well-
get the alternative network and that family is able to stay into that alternative network, then things should stay level for them. Should.
We just don't know how many people are really going to be. We just don't really have the information. We're being asked to consider something
That
a
we-
week later without proper.
We need the information.
Sufficient information, I think.
I agree.
Yes. But it's something to consider. What I think we should be doing is reducing both of those premiums for both the alternative and the OAP to the point where we get it down to 3.5, which was our goal. I don't think we should be exceeding that today.
I'm sorry, did you just say reduce premiums down to 3.5?
Reduce the premiums down so that we get the $3.5 million, the goal. Right now, we're talking about getting more than, right?
Well, I took away from last meeting, the 3.5 was from the plan design changes, not, you know, that the discussion between.
That's true. That's true.
Contributions. We're moving this around to drive migration. The premium adjustment here is really designed to drive migration to the alternate network. You know, what happens in what actually happens with the premiums, I think is going to be a board and union negotiation that's going to have to occur. But my takeaway from last week is we were looking to save $3.5 million by making plan modifications. That was my takeaway.
Yes.
Sure.
It's the alternate network doesn't look pretty. It really doesn't. But the truth is, Anthony, that most of the people who are going to do that, just so they can keep their premiums the way it is, are the people who are in all those larger populated bubbles from the bubble picture. You know, the ones who have less than $5,000 expenses, hardly ever meet their deductibles, those kinds of things. Most of those people are going to be the people who stay on that plan, right? Isn't that the general, the general thought? The people who are having the higher expenses and really need those specialty doctors. I mean, they could go to they could get just as good a care if they moved over, but if they're really concerned about that, then they can pay the extra premiums. But for the most, the majority of our employees are going to be, just fine at staying with the same premiums, not having to pay more, and really not having to choose very different doctors, because those are mostly people who don't go to the doctor very often at all. Does that make sense?
I hear you, but so are you going to give up your family doctor that you've gone to for 20 years and your kid's pediatrician and your husband's doctor?
I already looked up my pediatrician. That's the only one I care about. I'm like, can he go to Woostok?
Anthony, that's the thing is we've got to, that's why Jeff and I are asking for that data. A lot of that 80% disruption that we saw, like Chris was saying, a lot of those providers are also in the Steward and Parish network as well. So we wouldn't really lose them. That's the data we're looking for. We want to see that on paper
And if so,
to see who we're really losing.
So they may stay with their doctor, but when it comes time that if they have to go to the hospital,
They go to a different facility.
They may have to choose a different facility, but that's not changing their doctor, because their doctor would be able to go to that hospital
I
facility.
mean, are there really a lot of purely Health First doctors that have no other affiliation? See, that's what I want to see on paper before we get any further with this.
And Brian said he would have that to us by Monday. I know I didn't have it at the time, Anthony. I could see that on your face. But I'm hoping we will have that Monday. Brian, will you promise we will have it Monday?
You know, and I actually, while we were sitting here a little while ago, got onto the my Cigna website, and I put in all my doctors, and I was like, okay, which ones say only Holmes, because I'm in the South End, which ones say Holmes, and it actually still says Wusthof Healthcare Systems, but that's Stewart.
It's Rockledge Regional.
So which ones say both? You know, or mine don't do Rockledge because I'm in the South End, but you know, you can actually just kind of do a spot check of your doctors right now, and I checked some of them have both, and some of them only had Holmes, and you know, some of them had Palm Bay Hospital, which is a Health First hospital, so you can do a spot check right now, even before Monday. You have to go into my Cigna to do that.
Okay. We have 30 minutes left. What is next? Does anybody have any recommendations or suggestions from where we stand right now?
Do you want to look at plan design?
For which part? For the OAP?
Yeah.
Does anybody have any changes they'd like to see in the OAP part of the plan design?
Yeah, what if we, kicked up the deductibles another $500 and the out-of-pocket maximum's $500? What would that do?
From scenario 2?
I thought we were talking about scenario 1.
Okay,
now.
scenario 1.
For the OAP, it's like
Okay, just
tomato,
wanted to be
tomato, it's the same.
Just wanted to be clear that the starting point was, yes, they're the same.
It's the same.
Sorry.
For the OAP part.
Yes, so let me.
So Anthony, you're asking to move it from 5,500 to 6,000?
Yeah.
Okay.
And then the annual deductibles increasing 500.
So, okay, so individual out-of-pocket max, you said to 6,000?
We're
So
looking
the
for that
family
margin
out.
impact of $500 on OAP. Shouldn't matter either way, should it?
I'm sorry?
We're looking for a $500 impact for OAP, so it shouldn't matter which plan, which
Yeah.
one you're using, correct?
Right, exactly.
You're looking
That's
for
what
the
I said, they're
marginal.
the same.
Make sure, get the
Yes,
change.
yes, yes.
They're the same.
So if we do 6,000 for individual out-of-pocket maximum, then family becomes 12,000. Let me just make sure.
And did you also say for annual deductibles, you wanted to go up for 500
Yeah.
too?
Yep.
So up to 3 and 6?
Or it's
So up
2
to,
and
up to
4.
2,000 from 1,500?
Oh,
Yeah, 2 and 4 for in-network.
Okay.
Right, that's what you're talking about with the wellness.
Yeah. Yeah.
Right.
Just
Right, and that's all blended in behind the scenes of this. This is just that one layer. Okay, so those are the two changes only? See what that does for.
6 and 13.
Second, let me run it from here. Don't look at any numbers yet, because I need to change it to manual. Okay, so manual. Okay, so we have plan design savings of 4.5 million if you did the same thing for both plans.
How much was it again?
4.5 million, 4.498 million in just plain design savings.
If we
Anthony,
did that to just the
before-
PPO without an alternative network, what would it look like?
It should essentially be the same. There'd be some minor differences. Let's just check that.
Just like,
Anthony,
yeah,
were
it's
you
the same, because
asking
the plan
those
design is the
changes
same.
only, so all the co-payments and everything goes back to what we currently have? And those were the only changes you wanted to make?
no, I meant in addition to the changes
okay.
that
All
that
right.
were listed here.
so raising office visits to 45 and 90 still?
Yeah, just keeping all that the same, and then
And now we're at 4.5, a little over 4 million, right?
Right, 4.5 million.
4.5 million?
Okay, which if we keep the alternate network at today's numbers, we'd only get about half-ish of that, right?
If you keep the alternate network as your current plan design and you alternate the PPO plan design up to what's in the PowerPoint for scenario 2, that would be 3.5 million. I'm sorry, it'd be 1.75 million.
Okay. Or with the changes that you just made, it would be
2.25. Yeah.
Right, because
So
it's only going to impact that.
If we're doing this with only making changes to the OAP, what is the advantage of the narrow network now? What would be the advantage of adding the narrow network back in?
Because we get another 1.8.
Right, you get the alternate network savings that happens behind the scenes that the employee doesn't see that happening, but it's happening behind the scenes. If 50% migration, that's 1.8 roughly million.
Plus the 2.1 in employee contribution that she calculated.
If that's the choice on the employee contribution piece, yes.
But that's not what we're looking at. We're looking at plans. So the 2.1 is really, that's
Separate.
separate.
Right, so if you did this, you kept the same plan design for both. If you did add the alternate network at 50%, then you would see the 1.8 million of alternate network savings. Ignore this for now, this is assuming what you saw in the PowerPoint. And then the 4.5 million in plan change savings for, so if we total just those two pieces, that would be 6.3 million.
And plan change.
In plan changes,
All right.
if you offered both at the same plan design.
At the same plan design as today?
No, as they both step up to what you see, let me zoom in.
Are we able, we're not able to put the changes we just made just most recently and leave the alternative network in the 2020 space? Can we see what that would look?
Not today.
We don't have
The
that
next
ability.
time we meet, absolutely, we can separate them.
Okay.
Everything we've looked at up to this point, they've been mirroring.
Because, back to that
You're
idea of
basically
the
cut it
sweetener.
in half. 'cause
Half,
if-
yeah.
Just cut it in half.
Yeah, because if 50% of the population is going to stay on the current plan design. Now that, honestly, that may not be the way it actually plays out because you think some of your lower utilizers are going to be the folks that are going to migrate over. So
Just to save it up.
it may have actually, a greater effect than that. But I think that's hard to, that's a hard model.
Right, so if we do a really rough estimate of that being half of the plan change savings plus alternate network savings in 1.8, which could be less if it's that differential of the plan design, then it's about 4 million in total between plan change savings and alternate network savings.
But so without the premium increases, the alternate network is saving 1.8, and that is possibly a high estimate.
That is assuming,
50%.
and that's assuming 50% migration. The farther apart those contributions get, the possibility of having more migration to the alternate network. Certainly, if you lower contributions in the alternate network below your current contributions, I anticipate you'll see more migration as well into that, and that could bring in more of those people that would bring essentially the average utilization of alternate network savings.
Isn't that where we left off, though, that they were slightly lower? I thought that's the last scenario we looked at.
It
that
was.
It was slightly lower.
When we were talking about sweetening the deal to get people over, we looked at a 25% reduction in those premiums for the alternative network as well. And she'd run those numbers.
But that basically zeroes out your,
Zeros out the difference.
25% increase to the OAP, assuming a 50% migration, nets 2.1 in premium increase. If you go up and you go down, you zero that out, so that takes that 2.1 million right off the table. So you're not saving anything there. I would say, I don't know, Anthony, are you thinking a $2,000 deductible? Because that's a pretty big jump from where you are currently at $750. You're basically talking right now, we're talking a doubling of the deductible.
I wanted to see how much.
See what it did? Okay.
Yeah, how, if it would take it to 6 million or,
Are you getting a message from somebody?
I'm reading an email from somebody, but it's. things I think we've already addressed, so I think.
Okay.
Can I, so we're right now with the proposals that we've kind of discussed here, we're sitting about 3.5 with plan changes, not talking about the increase in out-of-pocket and deductible. So we're pretty much right around that goal, maybe slightly over. Can we see what it looks like if we reduced it to 20%?
Reduce the increase to the
To
OAP?
OAP to 20%?
And would you want to change the reduction to 20% as well to balance it?
Do you change the which one? I'm
If
sorry.
you look over on the alternative plan, she'd reduced it 25%. So to match the raise of the OAP to 20%, you would reduce the alternative plan.
I'm talking about the premium side of it.
Right, on the premium side.
I mean, she can, but the biggest thing in the end is just seeing, you know, how much is that 5%? I'm curious how much that 5% impacts it.
Right. So let's say we don't do anything to this,
Keeping everything else the same for
then
first.
it's 1.7.
1.7.
But I definitely think if the consensus of the committee is to look at any scenarios where we lower the alternate plan below the current, we will need to reevaluate the migration assumptions and impacts of that and look at that holistically versus just the employee contribution piece.
I mean, like for every dollar, like for every 1% more person that's moving over to the alternate plan, how much are we saving? I guess that's kind of the number that I'm looking for. You know, how much, because I know we're not going to save, I know we're losing that dollar, but we're also saving at the same time on the back end, which.
And realizing there's also a tipping point. If too many people go,
Well, yeah, I mean, would it be a
There's
good thing if
loss.
everybody went over there? It would be a good thing? Would it still be able to save?
I'm sorry, repeat the question?
Yeah, well, I was just saying, well, like the chair was just saying, if everybody went over to the alternate plan, no, how much would we lose in that scenario? No, how much are we saving compared to gaining in revenue from the OAP?
So essentially, if everyone migrated, and this scenario by chance still has your additional $500 built in for deductible and out of pocket, but just for sake of discussion, the alternate network savings increases to 3.6 million if everyone were to go there. Is that addressing what you were asking?
I'm sorry, say it one more time. I
So if
apologize. I'm visual, I can't see it, so it's
even if you
bothering me.
offered both plans and everyone goes to alternate network, the total alternate network savings is 3.6 million based on just the utilization of having that alternate network versus your larger PPO network.
So doesn't that just show us that there, once again, it's not savings, it's premium increases that is really what's at stake here? So, you know, why not have a better plan and just increase premiums? You know, why are we going to do all this? If everybody took the alternate network, we're only going to save $4 million?
No, that's just on the alternate network savings. That's not the plan change savings if you still make plan change savings.
No, but
But you're saying no changes? Okay.
yeah.
so are you recommending scrapping the alternative network and just sticking with what we have?
I don't want to say that yet. I want to see the doctors and so on in the plan, but I keep coming back to that this is a whole lot, which really what it is, it's just a premium increase with a slight hypothetical maybe savings and a reduction of doctors that our teachers can use.
I think the reductions were 10% off of current fees, so that's where the other savings would be. So yes, there is a premium increase from that perspective to encourage people to move to the different plan, but built into that is a 10% discount off of the fees. So that's where you're seeing that other reduction. Exactly.
And if we do something with the alternate plan, we give people a choice, but, you know, and they can not have a premium increase. But it also looks like, and this is all hypothetical, we're not talking, you know, what's going to happen, but it also looks like it gives us enough savings. It won't give us a 9.3 if we don't change the co-pays and things like that on the alternate network plan. But that takes care of not only the 3.5 million. I mean, then hypothetically, we shouldn't have to have additional premium increases If we look at the other thing, scenario 1, where we were changing up the plan, that's only saves 3.5. We're probably going to have premium increases on top of that. And like someone said earlier, that would be for everybody. This way, we actually have an alternate, we have an option. If you can really only, and you don't use it very often, you really want to keep, you can stay here and, and we might not have to have any more premium increases above just the people who want to go. Does that make sense?
Yes, it does, definitely.
So we kind of solved 2 of the 3 issues right here.
I'm starting to get the feeling that we've kind of hit a wall right now, as far as discussion goes, without the information that we've requested to move forward. So, Mark, is the plan to try, same time, same station next
Yes.
Thursday? Okay.
Does this work for everyone in this room for next Thursday?
And Dawn and Sheila as well, hopefully, can you join us next Thursday?
Yeah, I think I've got enough time to figure that out.
Here's what we'll do. Brian will get us that list, and I will email it out to everyone here on Monday. In addition, Amanda, can you run this on our regular chart so it's easier for them to see?
Yes, thank you.
I'm sorry,
And
on our regular,
you know how we have the scenario 1 and 2 in our PowerPoint?
in a PowerPoint,
Yeah.
so that we can do full screen?
So you'll be able to see that then. And my recommendation is we just come in and start there.
I agree, yes.
Because we voted on the tobacco surcharge, so that's there.
Yeah.
And if we can get through all of it next week, that would be great.
That would be great. That will be our plan. I will make that my goal. Okay.
Can I just say thank you guys, because this is a lot of time, and I know some of you are still working from your offices and not
Working harder now
working
that we're
hard, right.
at home. Yeah.
So just thank you guys. That's a lot of time.
Okay.
When we come back next week, Aon will be able to disassociate the 2 plans?
Yes.
By the way, I want to thank ABK for all that. I mean,
Thank you.
she has done an awful lot of work, and Aon has done a terrific job, from my view, on putting these scenarios for us and working hard to help us get where we need to be. So thank you, Amanda, and the rest of the Aon team.
And just to put another kink in there, we did agree to circle back at some point to the CCD, the Cigna
Yes.
Designated Care Network. So when we get finished with all that next week, we need to be thinking about that between now and next Thursday. If we make these plan changes, when we take the vote, when y'all vote on, are we also going to say Cigna Care Network? In addition to the extra $20.
We actually have that, plus we did add the specialty copay.
Right.
So we can talk about that as well.
For pharmacy.
For pharmacy.
Okay, so we'll start with plan design, we'll talk about CCD, and then pharmacy as well.
Okay,
Yes,
the
ma'am.
question on the CCD, since we're talking about on the alternate network that the copays would stay the same, premium would stay the same, then the question on the CCD, would that copay then basically stay the same?
Well, that's
kind of
what
thing?
the discussion would be, is instead of making it punitive to go to a non-CCD, how about we make it an incentive to go to one?
Right.
That was part of the discussion we started the meeting with. So I think like Katie mentioned, we have to circle back to that at the beginning of when we meet again. Okay? Is there any other discussion for the good of the group for today? If not, thank you for all your time. I will see you again next week, which would be the 14th. Yes, the 14th at 1 o'clock. Have a great day.